Hello, Kim. Can you hear me?
Good evening, sir. How are you?
I'm fine. I'm fine. How are you?
Good. Nice to see you.
Occasionally, we have to see, you're so
Ah.
far north.
Pardon?
You're so far north.
Yes.
Hmm?
And how is the COVID situation in Mangalore?
COVID is going on as busy as ever.
Okay.
There are a lot of cases. All the hospitals are full.
Yes.
Hello, Yuvraj.
Eh?
Yuvraj, how
Good
are
evening.
you?
Good evening, sir. How are you, sir?
I am good. I am at Rishikesh.
I know that. I know all your history. What
Yes.
all are happening to you?
Here now it is in lockdown and our OPDs are closed. Theaters are closed. Most of the patients admitted are COVID. There's a surge of COVID patients here.
The same thing happening in Mangalore. No hospital is free.
Ah.
No beds available.
Yes.
Good evening, everyone.
Hi.
Good evening, Kalyan.
Good evening, Kim. Good evening, sir, Dr. Venugopal.
How are you, Kalyan?
Hello.
I'm very well. I'm recovering from COVID pneumonia in July, so I was quite sick. So,
Nice to see you anyway.
Hello, Amlesh. Good evening.
Hello. Good evening. How are you?
I'm good.
Kalyan,
Mr.
did you know
Gopal
that
is
your
okay.
father... Kalyan,
yes, sir.
did you know that your father was an examiner?
Yes, I know that.
Your father was my examiner.
Yes, this was probably in Chennai. Was it not?
No, Vellore.
Yeah.
1968.
1968.
How time flies, sir.
You're still young, sir.
Me.
Good evening, Ramesh.
Hi, good evening. All well?
All well.
Thank
All
you.
is well.
Ramesh,
Sir.
today I saw a list of all the doctors who died in Karnataka. It's really sad.
Yes.
So many. I mean, quite a big list.
Yeah. Nobody has got a clue about what this disease is about, where is the end, how it behaves in different individuals. So,
We don't know.
as of today, we have 355 patients in our hospital.
As I was telling others, Mangalore, there is no bed available in most of the hospitals, private or government.
So, sir, I am Dr. Hemant Goel.
Hi, Hemant.
Hi, sir. Sir, so I think we should start. It's time. So, so today's, I think, Tarunji, should we start?
Yes, so
Yes,
we are absolutely
please.
live now. We are absolutely live now.
Okay. So today is day 2 of prostate cancer masterclass, and basically today we have 2 sessions. One is metastatic prostate cancer, hormone sensitive, and one session is metastatic castrate resistant prostate cancer. Each session has 4 lectures followed by a panel discussion. So without wasting time, I invite Dr. Professor Rajesh Sood, who doesn't need any introduction, for a welcome note.
Good
Sir,
evening, everybody. Welcome to the second day of this master class. And tomorrow again we are meeting for the diagnostics in CA prostate. This whole exercise is the part of our prostate awareness program and month which we are observing And you all know that 2007 onward, the PDAP program in India was launched, and world over in 1999, this program is going on of prostate disease awareness. There are 4 weeks, and there are in certain countries observances, week-wise observances. The second week is dedicated for prostatitis. The third week is dedicated for CA prostate, and the fourth week for BPH. So this is a small gland, but big problem. And Urology Society of India recognized it, started PDAP program, as we have discussed yesterday, and now we are doing it through Men's Health Society of India also, and this is part of Andrology India. You know, prostate has led to so many associations in India, and also so many groups which are working. We started, Dr. Kim, I am seeing there are Patrick Walsh when came to India. We started the COPE group also. We did certain trials also, and with ICMR we started the project also. Now again USA has taken over, and they are doing some data collection, and some guidelines are to be created, and we are under the Indian School of Urology again working on all the aspects of prostate cancer. This is the most important part for male cancer in India. The male cancers, this is in Delhi, we are sitting, it is already number 2. In Bangalore, it is number 3 male cancer, and very soon it is going to become number 1. Yesterday, we touched on controversies on diagnostics and localized or locally advanced cancer. And today, the metastatic cancer prostate, we are touching whether it is hormone sensitive or it is hormone resistant. So many aspects, and especially as we are now discussing various stages of prostate cancer, right from diagnosis to investigation, and which kind of investigation and what kind of treatment, and what are the complications, and what we can do during the COVID times. That is also important. Important part of our discussion. And what is happening, that is in this COVID time, new guidelines have come. 11 guidelines have come world over. Weekly review of the policies is there. There is no fixed policy yet. And every time we are revising, reviewing, and reaching to some conclusions. So in this all background, I welcome you all in this masterclass on cancer prostate. And this cancer prostate discussions are going to lead to our important urological malignancy, whether Dr. Yuvraj is there, Dr. Sudhir Rawal is there, and Dr. Bakshi, I can see so many doctors are here. They all are deciding what we should do, whether to go for surgery or the alternative radiotherapy, or we can modify the plans according to the risk categorization. And what is happening, those who are already diagnosed with the CA prostate and undergoing the treatment, what will happen if we are giving hormones? What will happen if we give steroids? What will happen if we are planning for immunotherapy or Olavapriv or pembrolizumab or other medications? This all is giving us a new thought, new normal of conducting our clinics, the telemedicine, and also the new guidelines, government policies, lockdowns, where the pandemic is showing new colors, and where the pandemic is under control. Everywhere the treatment is different. We have to weigh in our situation, in our environment, clinical environment, that how we are going to tackle a patient who is likely to be of CA prostate, who is likely to be treated for CA prostate, or already undergoing CA prostate treatment, or metastatic, or maybe till the last stages we are more prone to infections, more prone to situations where hospitalization or palliative care is needed. So all these aspects are to be discussed, and we have the eminent faculty and panel who are the masters of various fields, subfields of CA prostate management, and stalwarts like Dr. Venugopal, and also the USI office bearers, and all the ISU members are there in these panels. And I welcome again all of you for this masterclass day 2. Thank you.
So thank you, sir. So I directly start with the next session, and I invite our respected chairperson, Dr. Hemang Bakshi sir, and Dr. Kalyan Sarkar sir. Dr. Hemang Bakshi sir is a uro-oncologist. He is head of Department of Uro-Oncology and Robotic Surgery, SCG Cancer Center, Ahmedabad. And Dr. Kalyan Sarkar sir is a well-known urologist from Calcutta. And sir, I invite you both. Please proceed the session. Hemang Bakshi sir, Kalyan Sarkar sir.
Dr. Hemang Bakshi, please unmute yourself.
Yeah, can you hear me now?
Yes, sir. Yes, sir.
Yeah. So thanks for the invitation. And our first speaker for the session is Dr. T.B. Yuvraj, who needs no introduction, and he will be talking on hormone therapy, surgical versus medical, the pros and cons, and what to do, especially in these times. So over to you, Dr. Yuvraj, for your talk. Can you unmute yourself, Dr. Yuvraj? You are muted.
Yeah. Good evening to all of you. Good evening, dear teachers, friends. I thank Dr. Sood to give this opportunity. So, friends, I'll be discussing on the medical versus surgical castration, a long-standing debate what we have as all urologists, think still now we don't have perfect answer for this. However, I will give you a glimpse of literature where we can have certain guidelines. We have come a long way. Hormonal treatment, especially in prostate cancer and in general, and testosterone management, we had, if you see the list, we had 2 Nobel Prizes for this. So starting from Huggins, who did archirectomy and estrogen, we got a Nobel Prize for prostate cancer. And then the Charles, who invented LHRH agonist. I think the list is too big. So now when you see this list, so we have to go ahead and use appropriately, which is required in our clinical practice. Androgen deprivation therapy is the backbone of prostate cancer management in metastatic setting. However, so if you see the SIA data way back in 2010 or 11, only around 70% of the people use this ADT even in metastatic stage, and 30 to 35% of the people die without having ADT at all. So that is the very worrisome factor. None of the patient of prostate cancer should die of prostate cancer without taking hormonal treatment. That is the dictum. Our aim when we do this ADT is to get the level of testosterone less than 20, ideally, or probably it may not be possible, even less than 50 is acceptable. So we have, all of us know that there are methods of doing this. So mainly 2 important things, surgical castration and medical castration. Apart from that, all the medical or peripheral blockers are there, which support, not replace surgical castration or medical castration. So there are different types of medical castration. We have agonist, antagonist, and estrogens, but estrogens we don't concentrate on that. So we will be mainly discussing on surgical castration, agonist, and antagonist. If you see the bilateral archirectomy, it is the gold standard on which all the therapies should be compared. And I think there are many advantages to this. Quick acting, impending fracture, especially in bladder outlet obstruction, it is a very good method, and can be done under local anesthesia, OPD procedure, and very, very least expensive. So it's a very lesser cost is associated with bilateral archirectomy. The standard treatment what we all practice. However, it has got some disadvantages. So it is irreversible. So nowadays there is again the surge of intermittent androgen blockade is coming. So in that situation, it may not be feasible to do that. Psychological factors, although we underplay these things, so the patients, many people ask for it. So we have options available with us. So one of them is archirectomy, which has got its own advantages, disadvantages. Similarly, we have LHRH analogs, antagonists. So either it could be an analog preparation or antagonist preparation. The advantage is that compliance is good. So psychological benefit is there for the patient, and it is possible to do intermittent androgen blockade. Disadvantages, we have flare phenomena, and the cost is a major issue in India, and frequency of injection, especially antagonist. So the compliance is an issue, for the patient to come and take this injection. So I think we have pros and cons of both of them. And our question is that, is there all the forms of ADT are the same? Is there any difference? So if you see broadly, we don't know. So we don't have a broad difference of especially acting in prostate cancer. Whether it could be a decreased testosterone level or a controlling of the prostate cancer, or a complication like cardiovascular, urinary, or musculoskeletal complication. Let us see how this fare well in this scenario. So we have, historical literature. If you see whether LHRH analogs versus bilateral archirectomy, when the LHRH analog came in, so these trials were done. Although the numbers were less on that time, so if you can see, if you put it together, even a UOTS trial also comparing with the ciprotoluene acetate, so I think the results are almost the same when compared to bilateral archirectomy with LHRH analogs. So this is after that. So in 1990s, you had multiple trials comparing different formulations of LHRH agonists like goserelin, buserelin, duoprolide. And I think if you see these things, so there is not significant difference between these two as far as testosterone control as well as cancer control. So we have enough literature for this. So in addition to that, in 2000, we had a meta-analysis which says that, the multiple trials, there is no improvement in time to progression or treatment failure when compared to this thing. So then we had the introduction of antagonists, a major change in our understanding. So be a PSA progression-free survival, risk of death considerably less with antagonist when compared to agonist, and the drop in PSA level, drop in testosterone level is very fast, like a surgical castration. So then it came, so for a patients where we intend not to undergo surgery, but we wanted them to have a faster acting, I think this molecule becomes a big boon. However, so when they in the 2 years back, so they provided this data, say that 77% of the patient in metastatic has a PSA more than 50. So degarelizumab alive for almost 36 months. That means, so even there is a protocol or there is a proof that it improves survival when compared to LHRH analogs. It's very difficult to believe it, but that is the truth. So the major advantage was the difference was in the intermittent androgen blockade. So it was not there in between, but again it come back. So this is a major factor when compared to bilateral archirectomy. So in the present NCCN guidelines, so the guideline says that you do 7 months PSA if it is less than 0.2. Choose these patients for an intermittent ADT to prevent ADT related complications. So this is coming up in a bigger way now. So when you choose this type of treatment, I think there are multiple trials to support this the concept. So what about the side effects? We know that both the effects are same as far as cancer control is concerned. Side effects, we have a typical castration syndrome: loss of libido, rectal dysfunction, impotence, heart flushes, obesity, and you will get muscular strength decrease and fat deposition, osteoporosis, so on and so on. So this was this is the first time I read this paper. I was not knowing it. This is a SEER database, although retrospective, large patients, almost 35,000 patients, published in JAMA. If you see this, the comparison between archirectomy and GnRH agonist, as far as the side effects are considered, significantly higher side effects for LHRH analogs. The discussion went on, and there's 2 or 3 editorials for this. And how to explain this, both are the same, but even then they believe that the surgical archirectomy has a less chance of fractures, peripheral arterial disease, venous thromboembolism, cardiac related complications, and that is the reason at that time. So there was a big hue and cry, so where should we really doing it? But however, this is a retrospective study, we cannot give a complete opinion on these things. So as far as cardiovascular event goes, I think agonist and antagonist compared, lot of trials here. There are many trials with this, and you can say that 50% reduction in the risk of death and or even the cardiovascular new incidence of cardiovascular events is less with antagonist. So FDA warning came, so that all patients who undergo ADT should be told that there is an increased risk of diabetes and cardiovascular or cerebrovascular diseases in men with prostate cancer. So now the cardiovascular factor has become the second most common cause of death after prostate cancer in metastatic prostate cancer. So as far as urinary symptoms are concerned, you can see that, naturally, because Degarelix acts very fast, and you can get the reduction in the volume of the prostate very fast. I think it fares well compared to LHRH analogs, but we cannot compare it to archirectomy. It is again, it's an immediate effect. Musculoskeletal events, if you see that, if you see this study, considerably lesser incidence of musculoskeletal events when compared to LHRH agonist when we use antagonist. I think we have enough data, although no, there are many studies still going on to prove all these things, why this is so. But as of now, we have enough data to support this. So in the end, to recommend, so first line choice between archirectomy and LHRH analog. So it's just our choice, but still we have some proof that archirectomy is little better. Subcapsular total archirectomy, although I didn't tell it's an equivalent outcomes. LHRH flare, we see that in LHRH analogs, we have to treat that. No differences between archirectomy and LHRH as far as complications are concerned. No difference between different preparation of LHRH, almost all are the same. ADT associated with side effects like increase in CV events should be recorded and told to the patient. And when we use antagonists, it is got definitely there is no fluid phenomena, better PSA control, better cancer control, less side effects, and better for intermittent hormonal treatment. Thank you so much.
Thank you, Dr. Yuvraj, for a very good overview of the agonists, antagonists, and orchirectomy, and when should be using when, especially when compliance and cost an issue. Orchirectomy is a very good option. Just one observation that we might very soon see an oral antagonist in form of relugolix. The trials have been quite interesting. It's not there in the market yet, but that could be a game changer in the future. And for the next talk, I invite Dr. Raj Purohit for his talk on choices on metastatic hormone-sensitive prostate cancer, how to choose and what to choose when. Dr. Raj Purohit, please.
Thank you, sir. Thank you, organizers, and Dr. Sood for giving me this opportunity. And I think Dr. Yuvraj has very well covered this topic, and this, I think my topic actually is going to be addition to what he has told. So with respect to hormonal treatment for metastatic hormone-sensitive prostate cancer, so among these options which we have, which is the best option? So that depends upon the patient type as well as the comorbidities. So we all know that prostate cancer is the most prevalent cancer in men, and it almost constitutes 25% of all cancers in men in Europe and US, though the data from India is much lower compared to Western counterparts. But almost 1.2 million people are diagnosed with prostate cancer worldwide each year. And with increased longevity of human beings, the incidence is actually going to increase in future. And almost in 93 countries, prostate cancer is the main contributor to years lived with disability. And it's a very important aspect to the people whom we treat, that we don't give them more disability or we don't make their life more miserable. So that's very important when we're treating such patients. Most burdensome cancer among all males cancer worldwide in terms of disability adjusted life years. So with this, we all know that almost all our patients are more than 65 years or above. For patients when we're dealing with metastatic CA prostate, among these patients, only 15 to 20% patients will have no comorbidity. Almost 80% of patients will have some form of comorbidity, and 30% will have a history of cardiovascular disease. So this accounts to a very important aspect of prostate cancer treatment, especially when we're treating such patients with hormonal management. So as Dr. Yuvraj told very rightly, that surgical management in the form of bilateral orchirectomy is an important aspect, and especially in patients in India, many patients are not able to afford neither GnRH agonist or antagonist, and bilateral orchirectomy might be the best choice for them with respect to finances. However, in view of other psychological issues, as well as he mentioned that there might be a role now coming for intermittent androgen deprivation therapy, the role of reversible inhibition of GnRH might be an important aspect when we deal further, and probably next 2-3 years we'll have more data on intermittent inhibition of GnRH. So in the medical management, we have GnRH receptor agonist And now new kid on the block has been for last 5 years is GnRH receptor antagonist. Apart from this, we also use combined androgen blockage in certain patients in the form of androgen receptor blockers and synthesis inhibitors. Now, coming to GnRH agonists, so I will be talking only on the medical castration. So we have first and the more widely used agents, and which have been for almost 4 decades now, which are GnRH agonists, and they are synthetic analogs of GnRH and able to mimic the functions and physiological effects. Chronic exposure leads to down-regulation of GnRH, and especially LH gets cut off, and then that leads to inhibition of testosterone functioning. However, in the initial stage, such GnRH agonists can lead to a rise in LH and FSH and can lead to a testicular flare-up in the form of testosterone surge or flare. And the good thing is that they can be delivered at 1, 2, 3, 6, and sometimes on a yearly basis also. And they're often combined with anti-androgen to reduce the flare incidence. So the good points with them is that they are effective in lowering testosterone levels. The overall survival is comparable to bilateral occludectomy, which Dr. Yuvaraja had mentioned in those previous trials. And the good thing is that it is reversible, and therefore psychologically it is preferred over surgical castration. The negative or the flip side is that the delay in castration can happen, and especially there can be some testosterone surge, and which might not be a very good use, especially in metastatic setting. So that can also lead to some flare symptoms. Also, with such patients, they can have testosterone microsurges when we are giving them monthly or 3 monthly injections. And that can also have FSH and LS surge, and there can be sometimes FSH escape, and there can be some testosterone breakthrough which can happen. And the very important aspect has been hormonal adverse events and cardiovascular effects. Then we have GnRH antagonist, which is Degarelix. It's again a synthetic analog of GnRH and is able to bind and inhibit the GnRH receptor on the pituitary and leads to rapid decrease in the LH and FSH and testosterone levels. And this decreases as early as 3 days. And most patients actually achieve castrate levels by the day 3. And it is indicated locally advanced as well as metastatic patients. And the good thing is that it promotes rapid and sustained testosterone and PSA reduction, does not induce testosterone surge or microsurge, and there's no need for anti-androgen. It is reversible. Again, it also comes with some increase in the cardiovascular effects, as well as it has got more injection site reactions, as well as might be more painful than the GnRH agonist. And another logistic issue has been that it is only available in a 1 monthly formulation. So longer preparations are not available. So if we just see this data, we have seen that if we compare the PSA fall, it is markedly rapid as well as more sustained in the GnRH agonist compared to GnRH agonist. And with the patients who had a PSA more than 20 at baseline, that means patients who are high risk, it significantly delays PSA recurrence in the first year of treatment compared to GnRH agonist. Also, we could just see that risk of all-cause morbidity in men with prostate cancer who received brachytherapy with or without neoadjuvant hormonal treatment, we found that patients who had multiple risk factors, especially known coronary artery disease, had higher chances of myocardial infarction as well as failure with GnRH agonists. So this data was presented in the last presentation also. But if you just see the comparison of GnRH agonist versus GnRH antagonist, then this trial showed that there was a 56% decrease in the risk of cardiovascular events when Degarelix was compared to LHRH agonist in the first year of treatment. And absolute decrease was 8.2% and relative decrease was 56%, which was statistically significant. Also, when there was an open label study which was done in previously patients who had previous history of myocardial infarction or cerebral condition, cerebral vascular condition, ischemic heart disease, or PVD, the further risk of such events was markedly less in antagonist compared to an agonist. And also, the fall or the suppression in the testosterone was much sharper. Just by day 3, the levels were castrate compared to the castrate levels being achieved at day 7 to day 14 in the GnRH agonist. Also, if we just compare in patients who there were trials which were done in the patients who had LUTS symptoms, there was much better control of LUTS symptoms with GnRH agonist compared to GnRH antagonist compared to a GnRH agonist. So how do we choose a patient for which is the best modality in metastatic CA prostate. So a patient who comes to us, so a patient requires androgen deprivation therapy. If the patient is high risk, localized or metastatic, one option is surgical androgen deprivation therapy can be offered to many of the patients after discussion. If the patient is not fit for surgery or the patient does not prefer surgery, or there are other comorbidities, then the patient, we have to evaluate whether that patient has got a coronary artery disease, myocardial infarction, cerebrovascular accident, angina pectoris, or coronary artery bypass history. Such patients should not be offered GnRH agonist. They should be treated with GnRH antagonist. If the patient has none of this history and the PSA is high, the disease is metastatic, again, I think the preferred choice is GnRH antagonist in patients who have got more PSA more than 20 nanogram per ml, or patients who are metastatic, because antagonists will have faster decrease in the PSA, control of PSA longer for, and might also translate into a better overall survival. And in metastatic patients, there will be no clinical flare-up. Patients who have got also LUTS, there's a faster and better control with the GnRH antagonist. All other patients, a choice between GnRH agonist or antagonist is fine. I think this is just a concise presentation. And to summarize, prostate cancer is the most prevalent cancer in men, and the rising incidence has been because of the increased patient burden, because of increased longevity, as well as a better healthcare system. And a large proportion of these patients present with comorbidities, and they have to be importantly considered when we are deciding the androgen deprivation therapy. Among medical and medical pharmacological androgen deprivation therapies, both GnRH agonist and antagonist are useful, but in patients who have got high PSA levels, or who have got symptomatic LUTS, or who have got pre-existing cardiovascular disease, GnRH antagonist will be preferred over a GnRH agonist. Thank you so much.
Thank you, Dr. Rajpurohit. That was an excellent presentation. I have a question to you. I'm not sure whether your topic was covering the issue of chemohormonal therapy as well as the newer anti-androgens, and whether you would have any comment on how to choose which sort of combinations in the management of metastatic hormone-sensitive prostate cancer.
Yes, sir. So I think now even in metastatic CSPC, so the topic which was given was only a hormonal agent to choose. But so then now our choice has also included chemotherapy, especially in patients who have got more than 4 bony metastases, or who have got extra axial metastasis, or who have got a visceral disease, and who have got a PSA more than 20. So in these patients, apart from giving hormonal treatment, I will also be keen to add chemotherapy into their treatment. So that's one thing, sir. Then we also have data with newer drugs which are irreversible androgen inhibitors like abiraterone. And in non-metastatic setting, we also have data with the apalutamide. So these are the agents which are there in our management of metastatic hormone-sensitive prostate cancer, which was conventionally treated only with the hormonal inhibition, sir.
So the specific question was anything to choose between docetaxel versus, say, enzalutamide or apalutamide or abiraterone?
In my clinical practice, if a patient who has got a visceral disease, who has got a high Gleason score more than 7, who has got a PSA more than 20 and more than 4 bony metastases, I will prefer chemotherapy. Rest all, I might choose either abiraterone along with androgen blockage, or I might just go for androgen blockage and wait for patient to have worse.
Thank you very much indeed.
Thank you, sir.
I thank all the speaker and our chairperson for smooth conduction of the session. For the next session, I invite Dr. Ramesh Gowda, who is the head of Department of Urology and Renal Transplant at MS Ramaiah Hospital. Dr. Anant Kumar, sir, is Chairman, Urology, Renal Transplant and Robotics, Max Saket, and he is President, Urological Society of India. Dr. Kim Menon, sir, is Senior Urologist and well-known, he is a professor in AIIMS Rishikesh. Dr. Munir Khan, sir, he is a well-known urologist from Srinagar. So, sir, I invite you all for conduction of next session. Over to Dr. Ramesh, sir.
Yeah. Thanks, Hemant. At the outset, I would like to thank Dr. Sood and his whole team for inviting us over to chair this session. It's been an exciting session since yesterday. And without much ado, we can begin the session. All of us are aware that we need to alter the interior androgen milieu of a patient who has got metastatic disease. we need to now look at what we need to do for the local disease when you're treating a patient with M1 disease. To tell us about this, whom to treat locally and when, we have Dr. Anantkrishna Shivaraman from Chennai. He is a consultant at the Chennai Urology and Robotic Institute, and he will be talking, taking us through about local treatment in metastatic disease, when and whom. Dr. Shivaraman, Anantkrishna Shivaraman.
Thank you, sir. Let me share my screen.
Yep, you're on.
Is the screen visible?
Yes, you're on.
Okay. Thank you. Good evening to all the participants. I must thank Professor Dr. Rajiv Sood for giving me this opportunity and the chairpersons for the introduction. So my topic today is a treatment of the primary in metastatic prostate cancer. Right? So if you look at the natural progression, you have preclinical phase, you have a primary disease phase in which local treatment is done, and then you have salvage treatment, and then you have this area which is metastatic hormone sensitive prostate cancer. And in that, you have this metastasis, big group of metastasis, out of which is there a subgroup where a limited number of metastasis, you would be able to probably give them a better outcome than the other people who have polymetastatic state. So this is where we're going to concentrate today. Right? The first one is, what is this subgroup? What is this oligometastatic subgroup that may potentially have a better cancer-specific survival or overall survival? So it was initially proposed by Hellman and Weichelbaum in 1995. It probably straddles the Hallstadian theory where you have contiguous spread, which is starting from the primary lymph nodes and then blood spread. And it straddles the Hallstadian theory and the systemic hypothesis. The systemic hypothesis states that cancer is a systemic disease from day one, and you only see a local manifestation, but there are multiple microscopic metastases even on day one. So oligomets is an intermediate state, and we're interested in it primarily because it is potentially curable or it has superior cancer-specific survival when you compare it with polymetastasis. So if you look at this diagram, and you have this localized disease, and then you have this polymetastatic castrate-resistant disease, and you have the state in between, which is more toward the localized disease, and potentially benefit from local treatment and systemic treatment as well. All of us, when we were 20 years ago, when we were studying, as soon as we heard the term metastasis in prostate cancer, they either have orchidectomy and then go on to have chemotherapy at a later date. But other tumors, for instance, colorectal cancer, ovarian cancer, have taught us that even in the presence of metastasis, treating the local or the primary has some benefit. So can we apply this to prostate cancer? So if you look at microRNA analysis, oligometastatic and polymetastatic are slightly different when you look at the microRNA analysis, suggesting that they are distinct entities. It could be that they are different points in a continuous evolution, but more likely that they're distinct entities. And oligometastatic can be considered a heterogeneous disease with distinct metastatic phenotypes. So the boundary between oligometastatic and polymetastatic varies from between 3 to 5. And how did we arrive at this? That's a big $1 million question. So oligometastasis is we're concentrating on this entity towards the left, which is de novo or synchronous metastasis in the oligometastatic group. We're not going to concentrate, as far as this talk is concerned, of oligorecurrent or oligoprogressive disease. So what is the definition of oligometastasis? As you can see, it leaves a lot to be desired. People have started from less than 5 to 1 metastasis. And apparently in the 2017 APCC consensus conference, nobody could reach a decision on what an oligometastatic disease is. But currently in the guidelines, a lot of us are following the charted criteria, which is less than 4 metastasis and less than one, including outside the vertebral column of spine, and no visceral metastasis. So I think it's reasonable that we follow the charter criteria for categorizing oligometastasis, but this has a potential to change in future. So we have a three-tiered approach for treating the oligometastatic disease. One is local consolidative therapy of the primary tumor. The next is metastasis-directed therapy. And then finally, systemic chemohormonal therapy, which we've been talking about and which is current standard of care. So, and also another thing that we need to understand is most of the studies that looked at this category of oligometastasis looked at it with conventional imaging, which is bone scan. With the advent of newer imaging such as PSMA PET scan, we're seeing more and more cases that could potentially fall into this oligometastatic criteria or be pushed into polymetastatic because they've been diagnosed with the PSMA. So what are the principles of treatment? Aggressive treatment to the primary can potentially improve overall survival. And treatment of the primary definitely reduces palliative interventions for locally advanced disease. And we have this potential to reduce ADT when we are talking about metastasis-directed therapy. So local therapy to the primary, where are we at present? When you look at this trial, Stampede Arm H, there's a definite survival benefit in terms of overall survival is at least there's a when you look at 3-year overall survival, it's around 73% for the control versus 81% for patients who had radiotherapy. So definitely a 7 to 8% increase in overall survival when you talk about radiation for metastatic hormone-sensitive prostate cancer. And there's a 17% improvement in failure-free survival as well. So that's a significant improvement. The next, sorry. So again, the stopgap analysis, which looked at several studies, again came to the same conclusion about, sorry, one second. So same conclusion, which said the addition of prostate radiotherapy to ADT should be considered for men with metastatic hormone-sensitive prostate cancer who have 4 or fewer bone metastasis. So because of these two studies, the current EAU guidelines, this has found its way inside. So we have to offer androgen deprivation therapy combined with prostate radiotherapy to patients whose first presentation is M1 disease, but who fall under the charter criteria. Previously, the recommendation was considered weak, but now it's strong. And again, it also states that don't offer patients local treatment if they have polymetastatic disease. So we know that radiotherapy works in the oligometastatic setting, but can we extrapolate this to surgery? And this is what we're going to look at now. So what is the rationale for radical prostatectomy? Definitely improves local control, removal of a persistent source for future metastasis, and improved response for systemic treatments. So one other reason is systemic treatment increases the clonal heterogeneity of the tumors. So we have a potential to stop that by doing a radical prostatectomy for these patients at presentation. And I'm not going to talk about nodes. I think Dr. Venkatramani is going to talk about nodes immediately after me. So let's just concentrate on METs. So these two studies, which looked at the safety and feasibility. The first one is by a good friend of mine, Prasanna Suryakumara, looked at 106 men who underwent radical prostatectomy in the setting of metastasis. And they found an overall survival of 88.7% at 22 months, showing that it's a safe surgery to do in the presence of metastasis. Next, you looked at the feasibility of this. And there's a German paper, came out in JURL in 2015, looked at 23 men versus 38 men who had ADT plus RP versus only ADT. And the cancer-specific survival was 95.6 versus 84.2. I know we're looking at surrogates. We're looking at PSA-free survival. We're looking at cancer-specific survival. We're looking at symptom-free survival. But the million-dollar question is whether it really impacts the overall survival. But these are reasonably good surrogates to follow. And definitely when you looked at registry data, for instance, Hamburg, the Munich Cancer Registry, and the SEER data, it showed that surgery did definitely improve survival. The other thing that we all talk about is surgery reducing local complications, but have we ever proved this? Now, this is an Australian paper, looked at a good number of men who've had radiation, external beam radiotherapy, and no treatment to the local primary in a setting of metastasis. And you had this 55% people had complaints in the local site when they didn't have any treatment for the local, versus only 20% of men who had radical prostatectomy. Again, the end result is, and they concluded by saying that in the present retrospective analysis, it supports the hypothesis that the primary treatment, prostatic treatment, gives palliative benefit to men who later develop CRPC. And out of which, radical prostatectomy was associated with the lowest local complication. So who are the ideal patients for treatment of primary by surgery? Number one is they should have the footprint of oligomets. Don't consider polymetastatic patients for surgery. The low volume, low risk, low in terms of doubling time should be reasonable. The performance status, a good performance status, should be patients who could easily undergo surgery, well-motivated patients, having good response to ADT, no visceral mets. The visceral mets patients don't do very well, and not willing or not suitable for radiation. You have a good subset of patients who are potential candidates for radiation, who are not willing and not suitable. So again, these patients are candidates for radical prostatectomy in a metastatic setting. But I would be failing my duty if I didn't talk about MDT, which is metastasis directed therapy. Let's just look at one slide, one study, the STOMP paper, the surveillance or metastasis directed therapy in oligomets. And ADT free survival was 34% with MDT and 8% without MDT. I think this is something that we should keep in mind. And the CRPC as well was 76% versus 53% without MDT. Again, very good data, but I think we need to have further robust data if we're going to follow this. So let me finish by talking about the Will Rogers phenomena. Are we really falling into the Will Rogers phenomena by talking about treating the oligometastatic disease? Because previously we were looking at conventional imaging, which was bone scan. Now we have the PSMA PET scan, which potentially pushes more patients in the locally advanced group into the oligometastatic group and making the locally advanced do better, and potentially pushing more men from the oligometastatic group into the polymetastatic group and probably improving the outcomes of the oligometastatic group as well. Classical Will Rogers phenomena, but I think there's a real risk of us getting into this. So what are my take-home messages for treatment of the primary in oligometastatic disease? Number one is there's definite evidence for radiation, and it is in the guidelines now. There's definitely potential for surgery, because when you talk about surgery, it does definitely control the primary. The only thing that potentially radiation has over us is something called an abscopal effect, which is when you have radiation to the primary, they elicit an immune response which can act on the secondary sites as well. And then some evidence to say that this same abscopal effect can happen in surgery as well. So there's definitely potential for surgery, and especially in patients who can't have or will not have radiation. And surgery does decrease local complications. We do have to wait trials that are currently happening, the trombone and the SWOG study, as well as a few other studies that have started to look at this. So thank you very much for this opportunity. And I hope this clears a few of the cobwebs we have regarding treatment of the primary in oligometastatic disease. Thank you.
Sir, you need to unmute yourself. Ramesh sir, you need to unmute yourself.
I have a question for Anandakrishnan. Can you hear me?
Yes.
Yeah, you mentioned about the role of surgery in oligometastatic disease, but along with that, is there a role of neoadjuvant ADT also in this subset of patients?
I think several studies are looking at it at present, and initial data is suggesting that neoadjuvant. You're talking about neoadjuvant hormone treatment, isn't it? Did I
Yes,
get-
correct.
Yeah. So in future, I think this will come into vogue. So even as it stands practically, we're seeing patients who initially started with neoadjuvant hormones and then they come to us for further treatment. So definite, I think in future, there's a definite role for this.
Thank you.
I think we'll move on to the next talk. I'll invite Dr. Vivek Venkatramani. He is a consultant urologist at Nanavati Hospital, Mumbai, and he will run us through the role of surgery in lymph node positive only metastatic disease. Dr.
Good evening,
Vivek.
everyone. My thanks to Dr. Sood and the organizing committee for this opportunity, and thank you to the respected chairpersons. So today it's a very specific topic that I have been given. It's to discuss the role of surgery in pelvic lymph node only prostate cancer, metastatic prostate cancer. So what I'll be covering this evening is how do we stage the pelvic lymph nodes and what is the risk of lymph node involvement in cases of prostate cancer. When we find clinical N1 disease, is surgery indicated and what is the evidence we have for it? I'll just briefly touch upon the role of salvage pelvic lymph node dissections. What I do not want to spend much time on is the adjuvant treatment if we detect nodal disease incidentally following a radical prostatectomy. So we'll just set the stage for this evening with a couple of cases I saw in February before all this corona. Seems like a long time ago now. So the first one was a 69-year-old diabetic male with a PSA of 9. DRE showed a smooth 50-gram prostate. MRI showed localized disease, Pyrads 4 lesion on the right side and no extracapsular extension. And biopsy showed about 2 cores, Gleason 3+4, both on the right side. Contrast this to the other gentleman, 51-year-old healthy African male from Cameroon with a PSA of 46. And he had a firm 35-gram prostate, MRI showing Pyrads 5, bilateral lesions, left seminal vesicle involved, but no really large lymph nodes, extracapsular extension present, and the rectum was free. And he showed Gleason 8 disease in all the cores that were sampled. So do we need further staging? In whom do we do it and how do we do it? So the recommendations in most guidelines do state that further staging for metastasis is important in those who have Gleason 4+3 or ISUB grade 3 and above, and also those who are classified as high risk and very high risk as per the various classification systems that we have. And how do we stage them? Well, CT and MRI for lymph nodes are very low in terms of sensitivity. MRI has not shown much benefit over the CT in this situation. Lymph nodes with a short axis more than 8 millimeters in the pelvis or more than 10 millimeters outside the pelvis are considered as potentially metastatic. The specificity of this size is quite good, but the sensitivity is very low, less than 40% in most studies. Diffusion weighted MRI may detect metastasis in very small, even normal size or smaller size lymph nodes below these thresholds. But if it is negative, it still doesn't rule out a lymph node metastasis. So what has changed in the last few years is definitely the PSMA PET scan. And Dr. Anant very beautifully suggested that in his talk as well. So this definitely increases the sensitivity to about 75% and specificity is almost 95 to 99%. It does increase detection in those with Gleason grade 4 and above and a PSA more than 10. But due to the spatial resolution of less than 5 millimeters of the CT, a small lymph node more, below that threshold may be missed. We also have a number of nomograms which are available to help us predict whether a patient is more likely to have lymph node metastasis or not. These have an area under the curve of about 0.75 to 0.80, which is very, very good. The most commonly used are the MSK-CC nomograms and the Briganti nomograms, which were updated, initially published in 2010 and updated in 2017, and even with incorporating MRI findings, they recently published that as well last year. So the incorporation of MRI may also improve the area under the curve for these nomograms to about 85 to 86. There is one study which suggests sentinel node with ICG may be a useful technique to find out, but at present, really, it is just one study and very, very experimental. So when we have these nomograms, how do they affect our management? So a lymph node dissection would be indicated if the risk of lymph node positivity according to these is more than 2% as per NCCN or more than 5% as per the EAU guidelines. And this is a more or less similar template with the external iliac artery and vein, all the lymphatic tissue removed, obturator fossa, and both medial and lateral to the internal iliac artery. So when in the past, maybe 10 or 15 years ago, the recommendations were to begin with a lymphadenectomy at any radical prostatectomy, send it for frozen, and then abandon the prostatectomy itself if the frozen came out to be positive. But there is a lot of evidence that was accumulated that showed that even those patients who went ahead with the radical prostatectomy, they did show a significant overall survival benefit, even if the lymph nodes were positive in this situation. So now that really the practice of that frozen section has been given up. So coming back to these two cases, we can definitely see that a person on the left has a very low risk of lymph node involvement. I use the MSK-CC calculator. It's only 5% for him. And the one on the right, 89%. So probably I wouldn't have staged the one on the left with any further imaging, but he came with a PET scan. So now both of them have the same finding on the PSMA PET scan, both showing a single right positive external iliac lymph node and no further metastasis. So what do we do next? Do we proceed with a radical prostatectomy or not? Let's see what the guidelines say. So in clinical N1, it's a situation which may be seen in about 1.3 to 12% of cases. But I think with the use of PSMA, it's going to get more and more common that we are going to be seeing these kind of situations. So according to the NCCN guidelines, if the patient's life expectancy is more than 5 years, you offer radiation therapy for the primary, ADT or ADT alone. Abiraterone in this setting, there's just one study, so it's a low-level recommendation, not yet standard of care. And if the life expectancy is less than 5 years, observation or ADT is suggested. This particular scenario was updated, and there's a new guideline in the new AUA guidelines of 2020. So they suggest some form of local therapy with long-term ADT in this situation. So they leave it to the clinician as to which form of local therapy they would use, because the evidence for any of them is quite weak. And they also say that offer RP in this clinical N1 situation only as part of multimodal therapy, which is a strong recommendation. So what is the rationale for local treatment? So it is similar to the oligometastatic state as well. There is a cytoreductive effect of surgery and the abscopal effect of radiation therapy, which is more likely to lead to an improved survival in these patients. With surgery, there may be a potential for cure in a small subset of men who have just 1 or 2 sites of lymph node metastasis, and 30% of men with clinical N1 may turn out to be pathologic N0. So the accuracy of staging is second to none when a lymph node dissection is performed. So this provides us with excellent prognostic information to classify these men further. So this is an important benefit of performing a lymph node dissection in these cases. Lymph node metastasis at RP have been shown to have even good outcomes without ADT. This was a study from MSKCC published in 2014, built upon a study from the Mayo Clinic as well in 2007, which showed that up to, without giving ADT, there was a very good 10-year overall survival, cancer-specific survival, and metastatic survival, almost over 60%, even in men who had positive lymph nodes. However, if there were more than 3 lymph nodes positive, that was a very poor prognostic marker in these particular men. So coming on to the available data and why the recommendation from the EAU is only a weak one, we see that there are about 5 or 6 trials. They're not trials as such, they're all observational database studies. So this makes the level of evidence very, very low. The only studies which show a benefit for surgery are the ones by Sison et al. In 2018 from the NCDP, which showed that the overall mortality-free survival for any form of ADT was about 78.8% with local therapy versus only 49.2% with ADT alone. The other trials above this were predominantly all looking at radiation in this particular group. The Stampede data showed a failure-free survival, again better for ADT with EBRT versus ADT alone, with an excellent hazard ratio from the control arm of the Stampede trial. One more couple of recent studies showing from radical prostatectomy, no difference in overall survival in the study by Moschini et al. 10-year overall or cancer-specific survival for N0 or N1 disease, but this is a very old cohort of patients. And recently, last year, published in 2019, another small Veterans Affairs database study, which showed significantly better prostate cancer-specific mortality and all-cause mortality with RP versus no RP in this particular scenario. We too had presented a paper in the AUA in 2017, again from the NCDB, and we could see a significant benefit of any local therapy versus no local therapy in N1 disease, again with a very, very strong hazard ratio of 0.65.
We have just crossed the limit for the time. So
yeah, I'm almost done, just 3 more slides. Yeah. So the systematic review suggested that there is a benefit to local treatment. However, the degree of bias is very high and a lot of confounding. Database studies tend to overestimate subjects and populations will overlap. They're all observational, no RCTs, low level of evidence. There is a heterogeneous selection and assessment of these patients. Actually, there's no data on ADT at all available in the SEER database. So those studies need to be taken with a pinch of salt. So just one more paper which attempted to stratify the nodal burden, and as we saw, worse prognosis with more than 3 lymph nodes, retroperitoneal lymph nodes, and Gleason 8 and above. So these both patients, the one on the right was very keen to have the surgery. I was trying to push him towards radiation. Ultimately, we did do this surgery for both of them. One on the left, 0 out of 11 lymph nodes involved, and 1 out of 13 for the one on the right. He's not been able to follow up right now because of the lockdown, not able to fly back from Cameroon. So to conclude, the benefits of surgery which are potential, which need to be studied further. Lymphadenectomy is the gold standard for staging. It may be curative in those with a limited burden and cytoreductive in the remainder. It avoids undertreatment and allows sequence of appropriate adjuvant treatments. But as of now, the quality of data is quite low. Very limited data on radical prostatectomy. It is part of a multimodal approach. We need to catch up with the radiation oncologists to get better studies to study the exact role of RP in this situation. Salvage lymph node dissection recently published a paper which showed very poor overall survival outcomes at 10 years. So as of now, it's still investigational. So I wouldn't, since with the paucity of time, I'll just skip over that. So thank you all very much for this opportunity, and we'll stop the talk there. Thank you so much.
Yeah, is there time, Hemant, for some questions?
you can take 1 or 2 questions.
Yeah. Now, Dr. Vivek, the outcomes of patients who have got lymph nodes is still not very clear in the literature. So the difference would be whether one wants to do a surgical approach or a radiation. Though the EAU guidelines does recommend radiation, none of the guidelines have incorporated surgery in one of the recommendations for lymph node management. So the jury is still out on the verdict for local treatment when there's lymph node disease. So where do you think this will lead us down in the next few years or so?
Right, sir. So the EAU now has suggested some form of local therapy in quotes.
Yes.
So they leave it to us whether we use surgery or radiation. Like I said, we need to really catch up with the radiation oncologist. The data for surgery is very small, only 2 or 3 papers. But I think extrapolating data from the oligometastatic setting, it would seem to suggest that there would be a benefit to local treatment. And of course, we know that the local tackled with a surgical approach.
Yeah, thank you. We'll hand over to Hemant to continue the session and probably have more discussion in the panel on this issue.
So thank you, sir. So I thank all the speaker and chairperson for concluding on time and a very interesting discussion. So I invite Dr. Ganesh Bakshi, sir, for moderation of next session, that is a panel discussion on oligometastatic carcinoma prostate. Dr. Ganesh Bakshi, sir, is a professor and head of uro-oncology, Tata Memorial Hospital, Mumbai. And also I invite the panelists for the next session, that is Dr. Aditya Pradhan, who is Director, Urology and Renal Transplantation, BLK Super Specialty Hospital, Delhi. Dr. Umesh Sharma, Associate Professor with keen interest in uro-oncology in ABYMS and Dr. RML Hospital, New Delhi. Dr. Sameer Khatri, Senior Medical Oncologist, Director, Shastri Mukund Hospital. Dr. Sajjan Raj Purohit, Principal Consultant, Medical Oncology and Center Head, Max Super Specialty Hospital, Vaishali. Dr. Kriti Karwal, Senior Consultant, Radiation Oncology, Maras Hospital. And Dr. Pranav Chadda is Consultant Oncology, Radiation Oncology, Kokilabai Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. So I hand over the proceeding to Dr. Ganesh Bakshi, sir.
Yeah, thank you, Dr. Hemant. Thank you, Dr. Sood, sir, and the organizers. I have a very nice panel. So going ahead with it, Dr. Pranav, this has been discussed in the last 2 talks, but just to set the time right or the stage for the panel, how would you define oligometastatic disease?
So, Dr. Ganesh, I'll go by with the charted or the latitude definition. Hello, can you hear me?
Yeah, we can hear you.
Yes, so there are retrospective studies and the charted and the latitude trial. However, I just would like to make a point that since oligometastasis is more of a biological sort of a threshold, and I was reading some of the reviews last week in which there is a CDK12. If it is found to be inactivated, then the disease tends to behave more in an oligometastatic way. But otherwise, we are following the less than 4 or less than 5 bone metastasis and or visceral metastasis. That is from the charted and the latitude trial.
Okay. So moreover, I mean, we go for a clinical way rather than the CDK, which is still not in practice all over in the real world. So Dr. Pradhan sir, how imaging is important today? What are your comments on that?
Oh, Ganesh, can you hear me?
Yes, sir.
Okay, so as has been amply clarified in the earlier talks, all this data which is oligometastatic definitions have been on the conventional cross-sectional imaging by MRI or CT. We are now almost universally adopted PSMA PET, at least in India. So we need to actually see what we are using as our standard of imaging for the primary as well as on the follow-up study. So I feel what we need to be focusing is on what is the oligometastatic definition used in these studies.
Right,
we will have to adapt it to our practice, and probably we are going to find a lot more polymetastatic than oligometastatic because of the higher sensitivity.
So that's a very good take home from in the initial slides only, that we have to find our study of imaging, because the studies, if you go, they have been initiated quite early, and the Western countries probably were not so familiar with the PSMA, which India is quite ahead in. Going ahead to Dr. Sameer Khatri. So what is the rationale, if we talk broadly about giving any local kind of therapy?
So, as we know that this oligometastatic disease, it is an intermediate disease between the non-metastatic and extensively metastatic disease.
Yeah.
So, there is a potential curability in doing the local treatment and even the metastatic directed therapy. So, in various studies, it has shown that there is better cancer-free survival also, and curability is there. And this may be due to the local treatment, that ascorbyl effect, there is suppression of few cytokines as you have mentioned, and maybe there is a decrease in the size of metastasis.
Okay, so like we used to say in localized high risk and locally advanced, potentially curable, we want to bring down the oligometastasis, probably at least a good selection of them to a curable or a potentially curable level. So we go ahead with the case discussion. This is a 55 years, no comorbidities, LUTS, PSA 8.79, and MRI shows T2 hypointensities, multiple of them, EPE, right-sided SV involved and a focal lesion in the left inferior pubic ramus. That's the biopsy report, 4+5, a PSMA PET CT, increased PSMA uptake in the peripheral zone, plus focal lesion in the inferior pubic ramus left, and PSMA avid pelvic common iliac retrocaval nodes, staged as oligometastatic prostate cancer. It comes within that, it came within the less than 5, underwent bilateral scrotal orchidectomy, started on abiraterone and prednisolone. The BRCA was done here. 6 months later, PSA initial 0.9, PSA now is 0.019, PSMA PET CT repeated, signification in the PSMA expression in the prostate, complete resolution of the nodal and bone disease. So now planned for RT2 primary. So now are the questions actually. Dr. Umesh, the first actually lined up 3 questions are for you. So is the imaging modality, we have discussed this, but just it may be a yes, no. So PSMA PET scan, right?
Yes, sir. PSMA PET scan is good enough.
Okay. So the next question to you is this, whatever said and done, this is a metastatic prostate cancer. So would you propose to your patient only ADT as is there in some trials, or ADT plus any combination, which is today the standard of care in metastatic prostate cancer?
So I will go for this combination therapy of ADT with any of the abiraterone, either abiraterone, enzalutamide, or because there are
any specific backing or reason for that?
Sir, looking at the case, metastasis is a low burden, so I will go for the abiraterone in this case.
Okay. Okay, so no issues. So what I wanted to bring in here was this between the HORAD study, which was about local therapy, it used only ADT actually. And if you go by the Stampede H, which Dr. Anand Krishnan had just mentioned, in that it was ADT plus in most cases there was docetaxel used. So I fully agree with your Abienza in this particular case, but I was just wanting to bring the point like only ADT or some ADT plus combination. Dr. Sajjan, the next questions are actually for you. Would you like to super select patients within the OM group? Like we like to have a bias in everything, like Dr. Vivek presented about RP in that setting, but obviously we all have a bias in doing an RP. So here, any clinical biogenetic markers which potentially you would use to consider which patients you will push towards oligometastatic and then also offer local therapy to select those between good and the bad ones. Dr. Sajjan. Is not there? Okay, Dr. Samir, would you like to take the question?
Yeah. So, as such, there are no proven biomarkers or genetic markers. Few genetic markers like
yeah, I fully agree with you. I mean, this is about one thing I would say is a clinical response. Like in some patients, I mean, this patient, like you have got a fantastic response. Some patients, although oligomeds, you may not get such a good response. Another thing is some people do propose that maybe if we have a tissue, and if we do something like oncotype DX or something,
Hello.
we might get something reason.
But there is no proven.
It's not proven.
Yeah.
Then the next question also I can address to you potentially.
Yeah.
Would it be a local treatment in that case, or local plus say we should address also the pelvic regions?
So local is a must, and I think the pelvic should also be addressed along with that.
Okay. So consequently, if we talk about also surgery, it should also be local plus pelvic, like the lymph nodes one.
Exactly.
Okay. So Dr. Aditya Pradhan sir, these are your questions. So what results do you expect?
So let me just expand on your earlier experience
Right, sir.
from
Please.
the question. So we have established that this patient needs local therapy, and now you're deciding between surgery and radiation. So the decision, whatever you have taken on the local treatment, if we are looking at the data, what is the data? So the few articles which we have got, in terms of the local control, you have good 5-year and some studies up to 7 years, which are showing good local control for these patients. But in the long term, where the data, the largest data I've been able to find was from Australia studies, which have shown about 8.5 years follow-up. There they have shown some benefit also in cancer-specific survival. But like I told you, the quality of data is only the longevity up to 8.5 years. Beyond that, I don't think we have got long-term survival data. So to summarize, local control, very good results at the cost of higher morbidity. The few studies where these patients were selected, they amount to about 2 to 3% of the entire cohort which was selected in database studies. And in these 2 to 3%, the Clavien Dindo 2 and 3 complications were about 20%. So higher morbidity of local treatment when especially
Please mute yourself.
Is somebody else speaking here?
Yeah. Sir, you go on.
So like I was saying, if you are choosing the surgery arm, the counseling has to be at the cost of higher local complications, which we find to the extent of 20 to 30%, something akin to probably operating on the locally advanced prostate cancer.
Absolutely. I mean, again, sir has pointed out that what therapies in some actually studies, the OS has not changed. And another thing he said that in some, the CSS has really shown a benefit. And I just want to scrape through this slide. If it's been there for a few seconds actually. And if you see that highlighted ones, RP has done well in one study and it has not done so well in the other study. So I think it is all evolving data, if we should say like that. And what can happen if a radiation therapy is given at this to this patient right now? One of this is my option. Long-term control I might get something like a oligoprogression, or I might get something like what is called a polyprogression. As Sir has said, evidence for radical prostatectomy is mostly retrospective, and a prospective evidence is actually awaited. There are a lot of trials, and we should get something from the trombone study, which has been completed but awaiting results and final publication. So, Dr. Samir Khatri, the first two questions are again for you. Do you think the DFS achieved will be significant? I understand that there is no great data right now and a strong data. And if metastasis recur, what do you think that the time to CRPC would be longer than a usual case?
So whatever data we have, phase 2 studies of this Oriole study or the STORM study we were talking about of 54 odd patients or 62 odd patients. So they have clearly shown that the progression-free survival is more when we give this local treatment. And regarding this second, the CRPC-free interval is also increased those who receive metastatic directed therapy or the local therapy. So I think we will achieve a good DFS and a CRPC-free survival in this patient.
Okay, so we do expect a slightly longer time to CRPC also.
Yeah.
Yeah. Dr. Sajjan, are you there? Okay, he is again not there. So would you mind taking the next question?
Yeah. So
yeah,
so
please.
It is, but I will give ADT in this. I would like to give ADT. And in combination, as was previously said.
Okay. Because I just wanted to bring some thoughts into it. Like if we have really treated everything, then, you know, like in, I don't know if such a similar thing arises in renal cancer for you. I mean, we have treated everything.
Yeah,
and then
there is definitely a concept of ADT-free survival also.
Yeah.
And but it was addressed in again a phase 2 study.
Right.
And if we are going for ADT-free survival, then the follow-up will be a close follow-up, and with maybe 3 monthly PSA, and if the patient is symptomatic, PSMA scans.
Okay. So in current times, at least a better ADT would be, I think, good. So coming to the case 2, this was a 51-year-old PSA of 32, biopsy 5+5, 2014. And that time we had done a fluoride PET CT, negative for bony metastasis, as well as it has a CT of the whole body. So there was no metastasis anywhere else. Planned for EBRT plus ADT, given leuprolide, and the PSA dropped to 0.02. The EBRT concluded in December 2014. And that was the PSA. The nadir was 0.001. And there has been a clear-cut failure. April 2018 was when he was re-seen with a 4.07 level. And this was the PSMA PET scan at that time. So increased PSMA uptake in aortocable, para-aortic, common iliac, internal, external iliac nodes. Radiation was given only to the prostate in this patient. No bone or visceral met. So here we have a scenario where we have retroperitoneal nodes, and the patient was started on leuprolide again. And if you see the levels, they have again gone down. Okay, 0.002. That's the last level. So these questions are to both Dr. Aditya Pradhan and Dr. Aditi Agarwal. Maybe Dr. Aditi Agarwal, you can answer again first to us. Options you can exercise. This is a short summary about him. 57 years, fit. Now the PSA is 0.002, has technically had retroperitoneal nodes as recurrence, given leuprolide, everything regressed, probably at least gone down. Has family, working professional, anxious, inquiring for therapy. Dr. Aditya Agarwal first.
Yeah, so looking at the clinical history, he's a 57-year-old, not so old, fit, working professional, and he's had recurrence only in the nodes, though there are para-aortic nodes as well. So I would want to offer radiation therapy in the form of radiation to the nodes, the entire chain, with an escalation to the involved nodes, which would be a PET-directed therapy along with hormonal therapy.
So hormonal therapy is on anyway. So just to clarify your answer, we'll give radiation to the retroperitoneal plus the pelvic
nodes,
regional.
yes, sir. The entire chain.
Okay. Dr. Pradhan, sir?
Ganesh, I would like to actually, rescan him. You've had a good response.
Yes.
PSA has dropped significantly. So what is residual, what exists as active disease is the first thing I'd like to see. Maybe after 2-3 months, I see that the PSA stays progressively low. I repeat a PSMA PET, see what is left. And then
there is a possibility, sir, that the nodes would lose their PSMA and they would reduce to a sub-centimeter size. But then in that scenario, what will you do? Suppose she has answered the other scenario.
That's what I'm saying. Here we are in a gray zone whether we need to consolidate the local therapy with radiation versus augment the systemic part by adding ABI to his treatment and then continue on that. Because this is going to be otherwise, you're trying to discuss with the patient options of surgery versus radiation on one side versus augmented systemic therapy on the other side. I would be a little averse to going ahead with a full RPLND in this kind of a scenario.
Right, sir. I mean, giving radiation then to the retroperitoneal lymph nodes would be okay. But as you say, there is another thought that we can give only abiraterone. Okay.
Sir, considering the initial history that the patient was very high risk, actually, I would have been tempted to give nodal RT at that very moment. So I don't want to miss it now.
Fully agreed with you. So one question small to Dr. Pradhan. Would we term this as a oligorecurrent disease? Oligorecurrent?
I would say so, because this patient has only metastasized to one field, and after the primary or the
3 or 4 or 5 kind of.
Yes.
So
one,
this is
one
a
region.
63-year-old male, no comorbidities. PSA was 7.9. RARP in 2005. Localized disease, nodes negative 4+3, 7. Had incontinence and had a artificial sphincter put. And that is the table of PSA. post-op year 9, it was 0.16, post-op year 11, 0.44, post-op year 12.93, and a patient was quite intelligent, but he didn't want to actually do anything. He kept on doing PSAs. Post-op year 13, 1.1. That is when PSMA PET was done, and there was a right upper shaft femur single focus was seen. Biopsy done was adenocarcinoma. This was from the bone biopsy. Started on triptorelin and a 20 gray radiation given to femur lesion, which was apparently curative. PSA 0.03 after that. And first three questions are to Dr. Aditya Pradhan, sir. Post RARP, PSA 0.13 in 2013. So it's been a long time. Where did the disease come from?
Well, I think we have to assume this was micrometastasis, which was there, and
okay.
now
you take all your three questions, sir.
Yes. So the second you've asked me is it from the 2005 record? I think yes. And good biology, answer again is probably yes.
Dr. Samir, the next lot, the curative treatment for solitary MET and no adjuvant therapy, was that okay?
Yeah,
I mean, one hormone was given and a curative radiation was put. So, okay.
Okay. And regarding what the patient should expect, as there is no disease now, so a long disease-free survival we can expect in this patient. Yep. And the patient will be required to have frequent PSA as frequent as 3 monthly.
Okay.
And if he is symptomatic at any stage, then PSMA.
He should report back to you. But as a physician, do you expect again with that history, 2005, 2013, 2018, do you expect good for the patient?
Yeah, definitely. The biology is a slow growing type of a disease.
I mean, a gut feeling for you.
Yeah, definitely. So slow growing. So the patient will do good and may survive for long.
So that's a very small theory about metastasis-directed therapy, which Anant had already put. So I don't want to read also. But a metastasis-directed therapy in selected patients in these good trials have actually shown a good benefit. So that's with SABR, that's radiotherapy. And later in this patient, no hormone therapy was given. So that in a PSMA PET, we did repeat actually, although Dr. Samir Khatri said don't repeat. And we had a complete regression seen in that right femur lesion. So the PSA levels again were low, and in August 2020 it was 0.358. Now the patient is educated, very anxious. So Dr. Aditi, I mean, all this is for you. Is it alarming? What do you think? Will you do anything like evaluate?
So looking at the previous history also, though the levels are low, but they are persistently rising. So yes, I would also be concerned, and I would want to evaluate the patient with some kind of imaging, probably PSMA PET, because initially he has been metastatic once. So we might as well harbor metastatic disease again.
Okay, so you will not wait technically. So,
no,
so
I
the
will not.
PSMA PET did show a lytic lesion in that to a single one in a D8 vertebra SUV 6.3. And we finally concluded it as an oligo recurrence again in an earlier treated case of with RARP with a later curative RT2 solitary MET. Now the question is to Dr. Umesh. I mean, primary was treated in 2005. Again, it's a repeat of a question, but he's 79 fit, retired, active life. And the last two questions are for Dr. Pranav. Dr. Umesh, please. Is Dr. Umesh there?
Yes. So the final diagnosis, what you have made is, I think it is correct, because it's the disease is in between, it is coming out, and it is a part of the micrometastasis which is representing.
So again, it looks like a occult which might have gone from the primary in 2005 or before that, but he is damn lucky. So Dr. Pranav, now what would you do?
So doing a full body MRI, Dr. Ganesh here would be obviously better, because it might show barrow uptake in the other, in the axial skeleton.
I just put this question casually. I mean,
yes,
but PSMA PET is also a strong investigation. Although all literature does say that full body MRI like skeletal survey is fantastic.
Yes, the treatment options for this patient, I generally tend to go with the SIN score, the spinal instability. However, seeing the the
It's
PET
on the
image.
TP, it's on the transverse process actually.
Transverse.
So
So
he doesn't even have pain right now.
All right. So again, if the patient doesn't have pain, now there is a theory that to prevent an SRE, that is a cord compression, we can give radiotherapy, and again as an MDT we should. However, since it has recurred at another site, probably a conservative management would be putting up orthosis and going ahead with a systemic therapy. That is how I would think of.
Okay.
Both either ways. We have to justify based upon how things are in the spine.
Sure. So we had a MDT. This is kind of a plan because the literature or any guidelines, there's nowhere in such a recurrent and again an oligo-recurrent case like that.
Yes.
So coming to the last and a very short case. So this is a 85 years male, IHD, aspirin, clopidogrel, family history of prostate cancer known. And he was diagnosed in September 14 at the age of 79 with a PSA of 656, Gleason 4+3, and a bone scan done that time. Single metastatic lesion involving L1, bilateral orchidectomy only, September 2014. That's the PSA, the trend of the PSA levels. And if you see, nadir is 0.12, and then again increasing. May 2020, it was 3.93. No imaging done actually, but the son also is a doctor and he keeps on doing the PSAs. And then it again increased after 3 months. So 5.22 and a testosterone, which was less than 2.5. And that's the PSMA PET scan. Left iliac bone, left ala of sacrum, lateral angle of left sacrum. These are the, so Dr. Sajjan, I think is not with us. So I think I can ask one of the questions to you, Dr. Pranav. Was this right away oligometastasis disease to begin with? And is it CRPC now?
I think to categorize it as
so bone scan showing
probably
one
yes.
lesion, it is
yeah,
yes.
but yes. So as per the bone scan criteria, it is. Now we have to define our imaging. Yes.
I mean, that's also fine because 2014 was the time. So I think we all were also kind of doing many bone scans. So is it CRPC now?
So I need to do the serum testosterone levels.
That's 2.5.
Less than. Yes. So I would say yes.
That was 2.5.
Yes.
So
yes. And can we categorize still at it as oligometastasis? So as per definition, I think it's still the CRPC doesn't stand in the oligometastatic definition. So we can still term it as oligometastasis. This would be my take. I might be wrong.
No, I mean, you're correct. I'm not here to prove you wrong anyway.
No, because
this was just an interesting case, so I had put it. And I had read some literature where it seems to be termed as a oligoprogressive disease because it is a progressive disease from CSPC to CRPC and oligomet. So these are to Dr. Samir Khatri. So does it mean a good stage? Can we have some different therapy plan? CRPC, and you are a medical oncologist. Will radiation therapy still help you? And do we expect a still better outcome than the other CRPCs?
Yeah.
Over to you.
First, I will clarify it, regarding this oligometastatic or oligoprogressive.
Yes.
So when we are talking about CRPC, I will be more comfortable using the word oligoprogressive instead of oligometastasis.
Sure.
So that is for castrate sensitive. And regarding this progression also, there are two types of progression as is very evident. It may be synchronous or metachronous. And metachronous will definitely have a poorer biology because the subclones will be there which will be resistant to the treatment. So here we are dealing with the synchronous metastasis. So I will call it an oligoprogressive disease. It has a good stage or maybe the substage and has a good biology. So if can we have some different therapy? So I will go with the radiotherapy, the metastatic directed therapy in this patient.
I mean, can we have some different therapy in the sense he's already orchiectomized? So would you add anything and then give radiotherapy? That's another small sub question to you. I mean, you will add Abienza or something and give radiation.
Yeah, but he is now 89 years of age.
Okay, so and he's IHD, he is hypertension, a lot of comorbidities. So we would not like to do that.
Yeah,
I take that point from you.
Ganesh, my apologies, but can we wrap up in next 5 minutes? Ganesh,
yes, sir. Sir, it's done actually. This is probably the last slide. Yes, Samir, Dr. Samir.
Yeah, so regarding the last question, do we expect a better outcome? Definitely, we are expecting a better outcome in this. In spite of him being 89 years of age, still he can survive a good disease-free. He can have a good disease-free survival after an MDT.
Okay, sure.
Ganesh, can I just intervene here?
Yes, sir. You can carry, and we have finished the actually panel discussion. You
So,
give
looking
your
at the
point,
patients, looking at this patient's profile, the fact that he is
Aditya
under.
Pradhan, sir, I would also like you to give a take home in 2-3 sentences after this.
Yeah. So what I was trying to get at is 89-year-old, well preserved. Son is a doctor. I would actually leave this person alone. He's got a non-symptomatic vertebral transverse process involvement, nothing else.
Right, sir.
So let it become symptomatic if required, and then do your radiation at that point of time. Just leave him alone.
Okay. Okay. So Dr. Samir was also okay. Like, I mean, only ADT continued, no additional therapy, but just give a radiation so that his, as you said, that painful thing might itself get delayed. If we say that way.
Yes. He's
Okay.
currently asymptomatic, so probably you can wait till he becomes symptomatic.
Sir, would you also, I don't have a summary here, so would you give some 2-3 points as a take home on the panel of oligometastasis?
So my take is that this is an evolving field. If as surgeons we are going to operate, we need to choose our patients very selectively, as was brought out in the earlier talks. The second is that the most often will be at least dealing with a T3, if not a higher stage of disease, and therefore the morbidity of surgery is going to be a little higher, and therefore we have to balance our surgical interest in these patients versus offering them the alternative of radiation when we're talking of treatment at the primary. For metastatic directed therapy, I think we have to be very selective when we're offering surgery, and radiation probably has a stronger role in MDT. That's my take on this subject.
Thank you so much. Thank you everybody on the panel, and thank you Dr. Raju Sood sir. I hope the cases were good and everybody had a good discussion. Thank you, Dr. Hemant.
Thank you, Dr. Ganesh. It was really very interactive and very nice session. For next session, I hand over to Dr. Umesh Sharma. Hello. Yeah, so I hand over to Dr. Umesh Sharma for next session, that is metastatic castrate-resistant prostate cancer.
Good evening, all of you. I am Dr. Umesh, and the first session ends up in a time, and we are not too much delay. So hope this session also ends up in a good time, and we have we should conclude the session. So for the next this session, we have 3 talks in sub part of 2 sessions, session 1 and session 2, and followed by 2 panel discussions. So for the session part 1, I would like to invite the chairperson, Dr. Pavitran. He is a professor and head of Department of Medical Oncology, Kochi. Dr. Vineet Talwar, he is director, Department of Medical Oncology, RGCI, Delhi. Dr. P.B. Sivaraman, he is chairman of Chennai Urology and Robotic Institute. And Dr. R.K. Simpi, he is a consultant at Rajendra. So welcome to all of you. Sir, you can proceed from here.
Yeah, without much ado, we'll go to the next one. There is imaging of CRPC, what is possible and what is necessary by Dr. Shefali Sardana. Over to Dr. Shefali.
Dr. Shefali, kindly unmute yourself.
Am I audible? I am unmuted.
Yes.
Yeah. So let me share my screen. Yeah. Is it visible?
No. Yeah, now it is okay.
Yeah. So good evening, all of you, and very nice discussion in the previous topics. So being a medical oncologist, the topic given to me was imaging of CRPC. So I have tried to cover it from an oncologist perspective rather than going into nitty-gritty of each modality of imaging on the radiologist basis. So I hope I mean my slides would help you to define these imaging criteria in CRPC. So as we all know that castrate-resistant prostate cancer is advanced prostate cancer that is resistant to ADT, and over 80% of men with CRPC, M0 CRPC will progress to have metastatic disease. And in a significant chunk of these patients, the progression is quite rapid. So when we talk of defining imaging for CRPC, we should keep in mind that there are certain criteria when to do the imaging and how frequently to do it. Various committees, various working groups, and various international societies have tried to define those criteria, and few of them being that imaging should be initiated when considering starting the therapy for patients with CRPC, and also when the therapies are changed to establish a new baseline. And henceforth, with the advanced prostatic cancer treatment available to monitor the disease progression is also a defined criteria. The discordance between a response assessment with PSA and radiographic imaging has created a little confusion in identifying the disease progression at early, and therefore the role of next generation imaging comes into play. For optimal effectiveness, the following factors should be taken into consideration when deciding on the frequency of imaging. And these factors have been delineated by various guidelines and societies. These are the you should consider the individual risk, age of the patient, PSA doubling time, Gleason's grade, and overall patient health. And if any of the high risk factors is present, and especially once you are suspecting in M0 CRPC that PSA doubling time is less than 8 months, I think the scans should be performed more frequently as required. So one of the important topic in my talk was what is possible and what is necessary. So now coming to what is possible, once we talk of what is possible in today's scenario, so we need to understand what is the role of established conventional imaging, that is CT and bone scanning, and is there a defined and benefited role of next generation imaging technologies like whole body MRI, PET, and combined PET CT and PET MRI. Also defining their role in detecting the presence and extent of disease to support the modern advanced prostate cancer management. We need to understand, is there emerging role of imaging in evaluation of oligometastatic disease, like we discussed in the previous talks, that can we attempt a curative measurement in such kind of patients, and henceforth recognizing the growing importance of imaging in evaluation of disease and response to the treatment. Also, there is a need to appreciate the potential of imaging theranostics in guiding the patient care. And we need to understand, last but not the least, some of the potential and challenging of next generation imaging. So when we talk of imaging in CRPC, we are basically looking forward to detection of basically the nodal metastasis or the bony metastasis and other visceral metastasis, and especially deciding when to call it as a response. So once we talk of the detection of nodal metastasis, we know that diagnostic sensitivity of CT and conventional MRI sequencing in the detection of nodal metastasis is less than 40% in prostate cancer as defined by various studies. Various meta-analyses have also shown that diffusion weighted MRI is better than conventional CT or conventional MRI alone with the sensitivity of 60 to 70%. So then comes the role of next generation imaging in such scenario. And once we talk of PET CT and PET MRI, various radio tracers have been studied for their utility. And it is seen that fluoride or FDG PET for that matter has poor performance in patients with prostate cancer, because prostate cancer cells are usually not glucose avid. In contrast, radiolabeled choline derivatives, that is carbon PET and choline PET, are used to detect increased cell membrane turnover and effective prostate cancer PET tracers. In meta-analysis utilizing these radio tracers, it is found that the sensitivity and specificity of, for that matter, choline PET amounts to 92%. When we talk of more widely utilized nowadays, that is PSMA PET CT, it has shown higher sensitivity in the detection of nodal disease. In patients with prostate cancer, there is a greater PSMA expression seen with high Gleason score in CRPC and with patients on ADT. And in a meta-analysis consisting various retrospective studies, with pathology proven disease, PSMA had combined sensitivities and specificities to the tune of 86%. And it was seen that mean size of malignant nodes, which was missed on PSMA PET, was to the tune of only 3 mm plus minus 1 standard deviation. When coming and talking to the detection of bony metastasis in CRPC, we know that standard bone scan and CT are most widely used method because of their most common availability. And the early metastasis confined to bone marrow, however, may not show the bone scan or a CT tracer uptake, thereby limiting the disease detection. In various meta-analysis, it is seen that on a per lesion basis, diagnostic sensitivity and specificity with these modalities was to the tune of 59% and 75% respectively for a planar bone scanning, as compared to when SPECT was added, it was 90 and 85% respectively. The pooled sensitivity and specificity of CT in detection of bony metastasis are reportedly to the tune of 70%. Then if we talk of the next generation imaging, that is MRI, and that too a whole body MRI is most spoken nowadays. When compared with bone scanning and CT, MRI is more accurate in detection of bony metastasis. The whole body MRI is more sensitive than bone scanning, and choline PET CT even in detection of bony metastasis on a per patient basis. Although recent studies have shown a potential for PSMA PET in such situation. And once we are talking of PET, we have to talk about various radio tracers which are available, and it is seen that sodium fluoride PET, which is a bone turnover specific agent, has higher sensitivity in bony metastasis detection as compared to SPECT bone scanning also. However, it does share the limitations of reduced specificity in differentiation of malignant from benign osteoblastic uptake. It is unclear whether choline PET CT is more sensitive than conventional bone scanning, but it does have higher specificity with determining few indeterminate bone lesions on bone scan. And leading forward, other radiopharmaceuticals which are used in various places to detect disease in advanced prostate cancer but are not in very common use are 16-fluoro-5-alpha DHT labeled 18F, which binds to the androgen receptor, and hence in patient with CRPC it has reasonable sensitivity, that is to the tune of 86% in disease detection, and as an indicator of wild type wild type androgen receptor expression, it may indicate a response to anti-androgenic drugs also. And 18-flucyclovine PET, which is flucyclovine tracer, which is basically an amino acid analog, has a potential role also as a imaging tracer with PET, and I think it's most commonly utilized. Various US studies indicate that, and probably it is so effective that PSMA PET has also is not been still approved in US once 18F flucyclovine based PET scans are done in US centers. And coming to the last criteria of detection of therapeutic response, we know that PSA level alone to monitor treatment response is not recommended, especially in patients with metastatic CRPC, because of disease molecular heterogeneity, such as radiological progression can occur without increase in PSA level. So imaging is becoming more and more important in assessment of modern prostatic cancer-based treatment. But a major challenge remains the lack of objective defined criteria to assess response based on these imaging, and also disease confined to bone marrow, which is common in individual with CRPC. And we know that radionuclide bone scan is most widely used to assess the response assessment in CRPC with bony metastasis. So its criteria for response assessment are more validated. But it has substantial limitations as compared to recent imaging modalities available. And we know that bone scanning is unable to define new bone lesion in patients with diffuse bony involvement. Also, it must be repeated at 6 to 12 weeks after the first bone scan to confirm a disease progression, and enlargement of bony lesions does not sometimes qualify as a progression criteria because of the flare phenomena, which is most commonly known. So there comes the role of next generation imaging.
Shefali, can you sum it up? Time is up.
Yes.
Yeah.
So there are certain limitations for NGI, like there are no defined validated criteria for assessment of response, its limited availability, and of course the cost. And now that is why there is important to understand that what is necessary. So I'll skip the nitty-gritties and come to the guideline recommendation to choose what is necessary. So various EAU and ASCO guidelines have summarized that conventional imaging can be used for initial evaluation of PSA progression and should be continued to facilitate changes. But the use of NGI in this cohort is really unclear because of the paucity of prospective data on survival. And when a change is contemplated, it should be utilized. In men with metastatic CRPC with clear evidence of radiographic progression, NGI should not be routinely offered. And it may certainly play a role to select certain group of patients which were previously talking about, like oligoprogression, and once the therapeutic intent is changing. So my take home from this talk are, in CRPC, imaging must be individualized with aim of maintaining the patient's quality of life. The sensitivity of conventional imaging to detect regional, nodal, or distant metastasis is limited at lower PSA, that is less than 10 nanogram per ml. So the optimal strategy for imaging in asymptomatic men and those with lower PSA level is still not established. NGI has a potential role because of its more sensitivity. So the clinical relevance, but is still not established. Thank you for the patient listening.
Thank you, Dr. Shefali, for the nice coverage. Now I invite my co-chair, Dr. Vineet, to take over.
Yeah, can I request Dr. Chandragowda to speak about non-metastatic CRPC?
Thank you, sir. Thank you, Vineet, sir, for this thing. So I'll just share. Can everyone can see the
slides? Please share your slides. We are not able to see it.
Share it, sir. 1 second.
I am not able to see. Dr. Pavitran, are you able to see?
Not able to see, not yet.
Right, sir. 1 second.
Yeah.
Okay, yeah.
And now you can see, sir?
Yes, you can go ahead.
So thank you, sir. So my job is to cover a non-metastatic CRPC, whether, when, and how to treat. So I'll be answering in these 3 questions, so whether and when, and then how to treat. 1 second, sorry, it's not moving.
So you just have to say next slide and I'll change the slide.
Next slide, please. Yeah. So the considerations for making a treatment decisions, like whether and when. We initially before 2018, when the two abstracts were presented, before that we didn't have any exact criteria to say that whom we had to treat, whether we had to treat these non-metastatic CRPC where radiologically, clinically they do not have a disease, but the PSA is increasing. So then the criteria started defining the criteria. One of that is a PSA. The PSA doubling time was a most important factor to consider. The value of more than 10 or less than 10 was defined to see the prognostic, and if a patient has less than 10 months of PSA doubling time, those needs to be treated, and we have evidence now. And the role of molecular imaging, as has been covered by a previous speaker, is evolving, and a PSMA PET definitely detects more CRPCs as M1 rather than M0. So that needs to be seen. And in the futurist studies using PSMA PET, if you upstage the disease, whether if you treat them, whether that's going to make a difference in the overall survival, that needs to be addressed. Next slide, please. So the utility of PSA doubling time was defined by Smith et al. And he showed that the risk of bone metastasis as well as the risk of death is much more if the PSA doubling time is lesser. So less than 3 months with the median time to metastasis is progressively increases as the PSA-DT increases. So the risk of bone metastasis is 12 times higher if the PSA doubling time is lesser. And the risk of death is 4 times higher if the PSA doubling time is less than 10 months. Next slide, please. So these two would lay down the foundation of these the particular trials, how to treat. So we have a recent evidence three randomized trials of using 3 androgen receptor blockers, so to address this issue. Next slide, please. First among that is apalutamide. So this trial is a Spartan phase 3 randomized 2:1 trial, where the patients or an IDT on both the arms, where apalutamide was added in the one arm. So the patients who had a non-metastatic CRPC and the pelvic node involvement was considered, and the PSA DT of less than 10 months. The primary endpoint was the metastatic free survival, which was taken as a surrogate of overall survival, with the various secondary endpoints which are same to two trials. Next slide, please. So similarly, the Prosper trial in a similar design, 2:1, was addressed with the enzalutamide. Next slide. So if you just compare Spartan this Prosper trial, the patient characteristics are almost similar, with a median age of around 70 plus on all the arms, and the PSA doubling time or median PSA doubling time of around 4.5 months or 4 months in all the trials. So the bone-directed therapy, nodal status, all those were equally matched in these two randomized trials. Next slide, please. So if you can see the primary endpoint of the trial, which is the median, the metastatic free survival. So in that, the Spartan trial, the apalutamide has a hazard ratio of 0.28 with a 40.5 months of median metastatic free survival versus 16.2. Even in the enzalutamide, it's almost the same, 36 versus this 14.7 months. So in all the trials, there's 70 plus the percentage reduction in the distant progression or a death. So this was very significant. So almost 20 plus months of MFS benefit was seen in this particular these two trials. Next slide, please. So the secondary endpoints were the overall survival, because there was crossover in these trials. So hence the survival was statistically not significant because the statistical methods they have designed. But numerically, if you can see the recent one in 2019, which was assessed, again, this was presented in ESMO 2019. So the median survival with hazard ratio of 0.79 or 0.70 was noted in both the arms, which was significant. Next slide, please. So the other secondary endpoints was the time to PSA progression. In both the trials, you can see the Kaplan-Meier separating wide apart with apalutamide or an enzalutamide on the right side. There is a significant difference between the placebo versus the newer generation anti-androgens. Next slide, please. So if you consider the quality of life by FACT-P analysis, so both the trials, there is no difference whatsoever with the placebo ADT versus the enzalutamide or apalutamide with ADT. So the quality of life was not so different on adding these newer anti-androgens. Next slide. So the safety and adverse events, what was defined by were that only the major cardiovascular events and the deaths, which were slightly more in patients who have apalutamide and enzalutamide, who have been randomized to apalutamide. This was not explained in the trial. So we need to see into the details why the deaths were more common with the apalutamide or enzalutamide. Next slide. So the evolution of from 2018 is that the M0 CRPC, we now decipher them into whom we have to treat, whom we can observe. So by treating, by deciphering them into a high risk and treating them, we are going to achieve almost 20 plus months of the M0 CRPC to M1. So we can prevent, we get around 20 plus months for these patients who are M0 CRPC to M1 CRPC. Next slide. So this is one more molecule, that's a darolutamide, just for the completion, because we have 3 molecules. This is also with a similar design of a 2:1 of darolutamide versus placebo ADT, with a similar primary endpoint of metastatic free survival, slightly different secondary endpoints where they have taken some sort of a clinical endpoints of first symptomatic skeletal event, time to first cytotoxic chemotherapy, time to pain progression. So these were some clinical endpoints of a secondary endpoint which they have defined in darolutamide. Next slide. So the characteristics were well matched, and the PSA ADT, where here also the positive nodal nodes were there in 17 out of 83 in DARA arm. Next slide, please. So the MFS was significantly more with the DARA ADT darolutamide versus placebo, with 44.4 months versus 18.4 months, which is significant. Next slide. The other specified efficacy endpoints, like secondary endpoints, which I was talking about in terms of a clinical as well as the radiological, they were all significant. So the pain progression, the time to first cytotoxic chemotherapy, first symptomatic SRE, and the PFS, the PSA progression. So always significantly better in darolutamide versus only ADT arm. Next slide. So the adverse events which I was pointing out is the mortality. So mortality is slightly more with these newer anti-androgens, so that needs to be addressed. Only difference between among these three is that the seizure effect, the CNS side effects, are much lesser with the darolutamide, and then comes the apalutamide, and then the enzalutamide. Enzalutamide has the highest CNS toxicity and the seizure potential amongst these three agents. Next slide, please. So the hypothyroidism and cerebral ischemia are the two important effects, the class effects of these anti-androgens, which we need to address, as well as the mortality, as I was talking about. Next slide. So with this, the NCCN has recommended that patients with the conventional imaging negative for a distant metastasis, so radiologically negative, you have to continue ADT. If a patient has PSA ADT of less than 10 months, these three are one recommendation: apalutamide, enzalutamide with ADT. So that's what the recommendation is. Next slide, please. To conclude, in the past, treatment for non-metastatic CRPC included observation, measuring PSA ADT with serial imaging until metastasis was seen. That was the past. Due to the lack of guidelines and consensus in this unique disease space, patients were encouraged to enroll into the clinical trials. Next slide. So recently, a growing interest in the treatment of non-metastatic CRPC has been seen in an attempt to delay the progression to metastatic CRPC. The ultimate goal was to and it continues to be that the novel androgen modulating agents could be potentially delay the transition from non-metastatic CRPC to metastatic CRPC, prolong PFS, and eventually overall survival. Thank you very much.
Thank you, Dr. Chandragowda, for such a nice presentation. And I hand over to my co-chairperson, Dr. Shimpi, please.
Sir, I think you're muted. Dr. Vineet, should I go ahead?
If Dr. Shimpi is not there, may I request Dr. Senthil Rajappa to speak about the landscape of CRPC as of now. Dr. Senthil, please.
For the organizers for asking me to talk on this topic, which is the current landscape of therapy for CRPC, solving the treatment dilemma. So these are the various therapies for castration-resistant prostate cancer, and you see at the right half of the slide, which belongs to castration-resistant prostate cancer, is extremely crowded. So if you think that at the end of this talk, I'm going to tell you that your patient should be sitting on a conveyor belt which starts with an X therapy and goes on from one therapy to other till Z, you are certainly going to be disappointed, because that's not what I am going to do. What I will do is to take you through what we know, what we don't know, and then what I think, based on the evidence available today, should be the sequence of treatments for metastatic castrate-resistant prostate cancer. So what is it that we know today? Now, we know that if you have used docetaxel as part of your treatment for hormone-sensitive prostate cancer, then I don't think there's much of a role for reuse. There was a time when we thought reuse was efficacious, but I think the post-hoc analysis from the GETUP study clearly has shown that there are hardly any responses.
Sorry to interrupt you, Dr. Senthil. There is some disturbance from your background, I think. You can...
There's actually no noise on this side, sir.
Please reconnect your hands-free, your headphone. Please remove your headphone from the system and reconnect it.
Reconnect.
Is that better now?
So still the disturbance is coming.
You can.
Now?
Yes, it's better now. Okay.
Okay, great.
Okay. Good.
So sorry for that technological glitch. Right. The other thing that we know is that cabazitaxel is no better than docetaxel for first-line CRPC, and that's from the Firstana study. The study also clearly showed that 20 milligrams per meter square was as good as 25 milligrams per meter square. Now, what did we learn from the CARD study? The CARD study surely showed that if you have progressed within a year of abiraterone or enzalutamide or the other way around, using that again is as good as using placebo and is inferior to using cabazitaxel in that particular clinical setting. So that means it's within a year of using either of these agents. Now, PARP inhibitors, which are olaparib and rucaparib, are at the moment approved for use for patients who carry the homologous recombinant repair deficiencies, which you need to check either as a germline deficiency or as a somatic deficiency. And if your patient is harboring one, then you can consider these therapies for those patients. Now, olaparib is approved for use pre-chemotherapy and rucaparib is approved for use post-chemotherapy. So these are things that we reasonably know well. What is it that we don't know? We don't know whether docetaxel plus androgen blockade is better, similar, or inferior to androgen blockade plus the AR targeted agents, because we don't have a direct comparison there. Which AR targeted agent is best? I don't think we know the answer to that. We are using it based on the comorbidities and the adverse events rather than the efficacy itself. Do we have biomarkers? Do we have biomarkers therapy? I think the answer is no. Dr. Chandragowda clearly spoke about the SPAR studies. The SPAR stands for Spartan, Prosper, and the Aramis. Though they have shown nice improvements in the outcomes, in the PSMA PET era, just think for yourself what percentage of patients would really fall into castrate-resistant prostate cancer, but you're not able to pick up anything on the scan at all when you do a PSMA PET CT scan. There's a nice series which shows that 200 patients who were classified as non-metastatic CRPC, when they underwent a PET CT scan, a PSMA PET, only 2% were actually non-metastatic. So that's very, very important to keep in mind. What about reuse of ABI or ENZA after patients progress very late, a year, a couple of years or later, and have indolent disease? We don't have a clinical trial to answer that particular question. What we ignore most of the time is to ask our patient what is it that he wants. And many times we are also ignorant about the logistics and cost of therapy. Now, if somebody shows you a nice Kaplan-Meier projection saying that you should start with chemotherapy and end with the newer anti-androgens or vice versa, it's like asking, should you have the starter first or should you have the dessert first? Please remember that all of these are retrospective analysis and they have their selection bias. And you really can't come to any major conclusion looking at these Kaplan-Meier curves. At the end of the day, you have to really individualize on your patients. The other thing that we reasonably know well is that at any point in time, if you have a patient that's classified as poor prognosis, how do you classify them? Here's a big list of things that will put your patient into a poor risk category. If you have any one of these, then it's better to go on with chemotherapy rather than an anti-androgen or the newer anti-androgen agents, because there's reasonably good evidence that chemotherapy might be a better treatment for this group of patients. Now, what is the current sequence to be, and what is the future likely to be? And the answer is you need to personalize, personalize, and personalize. There's no one correct answer to this question. You can't put your patient, as I said, on the beginning of the conveyor belt and put them out at the other end. So let's come to the middle row, which is 2020. My tendency after ESMO 2019 has been to put patients on androgen deprivation therapy plus either of these agents, my tendency to use docetaxel has significantly gone down now. What do you do when these patients progress? If you've got reasonably indolent disease, and if you've got a HRR that is deficient, and your patient can afford this therapy, then olaparib is one of the choices. If your patient very rapidly progresses and has got visceral disease or one of those poor prognosis criteria, then it would be better to get on to docetaxel. And then following docetaxel, it needs to be cabazitaxel. What about reuse of the newer anti-androgen agents? As I said, if your patient progresses very late, has got indolent disease, there's nothing wrong in retrying this agent for that group of patients. For some reason you don't like olaparib and your patient has taken chemotherapy, then there comes rucaparib. These are standard therapies. Now I've listed 4 other therapies at the end of this row, which is PRRT, lutetium PSMA, something that I feel is being grossly underutilized at this point in time, primarily because we don't have randomized evidence. The randomized evidence that we best have is that it's better than cabazitaxel in terms of a 50% PSA response, but unfortunately they played down the potential of this particular therapy and lost the race, at least for now. RAD223 for patients who have bone-only disease, the good old Hornvan and dexamethasone at some point in time for your patients. What do I think will happen in 2025? Though that's not part of my talk, I'm very tempted to say what I think will happen later. I think lutetium PSMA will certainly come up this conveyor belt because it's likely to work better early when your disease is reasonably well differentiated. I think they will also get combined with abiraterone because there's evidence to say that using these PRRTs when your androgen is at its bottom does better, and the rest of the therapies come later. You could also do a comprehensive genomic profiling looking for all of these to see if your patient is a candidate for PARP inhibitor, as we said earlier, and immunotherapy. Please do not forget that these are based on evidence. But ultimately, at the end of the day, I always like to say the 3 A's, which is attitude of the physician and the patient, because it's important to talk to the patient and understand what he wants. Affordability and access, which is always a problem for us practicing in the place that all of us are. With that, if I've disappointed you by not giving you a conveyor belt approach, I didn't promise to do that, so you don't need to be disappointed. And that's the end of my talk. I will hand it over back to the organizers.
Thank you, Dr. Senthil, for usual lucid talk. Any questions from the house? If anybody has any questions, I think we can take one or
Dr.
two.
Senthil?
Yes, please.
This is Dr. Shimpi. Is there any role of low-dose cyclophosphamide with dexamethasone, maybe 4 milligram, in those patients who are not responding to maybe docetaxel or elderly people who are more than 80 years old?
I'm not aware of any strong data for the use of metronomic cyclophosphamide in metastatic castrate-resistant prostate cancer at this point in time. So the answer is no.
And is there any role of rechallenging docetaxel after cabazitaxel?
Unless you have run out of all the agents and you don't have a choice at all, your patient is still very well preserved, and if you have a long gap, then yes. But if you have a short gap, let's say a year or a couple of years, I wouldn't really to re-challenge anybody with docetaxel, or for that matter, any agent at all.
Okay. And have you any experience on radium-223?
I just had 2 patients. Both patients actually went to Singapore to have the therapy. So we don't have it at our hospital, but I believe that some centers are actually doing that 223. But I just have that short, small experience.
Okay, thank you.
Shami Mohammed has asked, can I answer that question on the chat box, or do we have time?
Yes, you can answer one question, sir.
Okay, one question. Why do you think docetaxel is less preferred in 2020? I think you're referring to the hormone-sensitive prostate cancer story. Though there is no randomized comparison, if you just compare the hazard ratios for docetaxel versus newer anti-androgen agents, the newer anti-androgen agents seem to be having a better hazard ratio there. And I also think if you have to learn from breast cancer, which is again a hormone, treated disease, there's lots of evidence now that you always need to start with the hormones for patients who are hormone sensitive and then get on to chemotherapy rather than the other way around. So I also treat breast cancer. So I'm tempted to say that hormones first, chemo later. And that's what the cross comparison also says. So that's the reason why I don't prefer docetaxel in my patients. Great. I think we can move on and I'll hand it back.
Dr. Umesh, sir, you need to unmute, please. Dr. Umesh, please unmute, sir.
Yes, I'm audible. So for the next session, I would like to invite the chairperson, Dr. P. Venugopal. Sir is the senior most urologist and is the founder chairman of urology at Kasturba Medical College, Bangalore. Dr. B.B. Singh, welcome, sir. He is a consultant EBS urology at Varanasi and ex-HOD urology. Dr. Anish Srivastava, he is a well-known faculty from and the professor head of urology at SGPGI Lucknow. And Dr. Sameer Khanna, he is a consultant uro-oncologist at Action Cancer Hospital, West Delhi. So over to you, all the chairpersons. Dr. P. Venugopal, sir, you can lead the session now. Thank you.
Thank you, Umesh. I got very good panelists as co-chairman, Dr. Anish, Baby, and Sameer Khanna. I would request the three of them to take forward the discussion of the program that is to follow by Shamim, Andrasa, and Ranjit. I think each one of them can take over one speaker and take it over and end it to a close. All subjects are diverse subjects, so it is not possible for each subject to be, coupling all the talk together may not be possible. I think I'll ask Anish to start the ball rolling.
Thank you, Professor Venugopal, and good evening, everyone. So we have heard a lot about the different aspects, and now we are going back to how the basic things like the imaging from the radioligands or the molecular pathology, etc., will help us. So may I invite Dr. Shamim Ahmed first to go ahead with his talk on the current and future radioligand. He's a renowned nuclear medicine physician. Dr. Shamim Ahmed, please.
Good evening, everybody. Thanks, sir. First of all, I would like to thank Dr. Rajiv Sood and team for inviting and giving me this opportunity to talk on this. I will be discussing current and future radioligands in prostate cancer. There are three important imaging modalities are in nuclear medicine which are used for prostatic cancer imaging. They are like gamma camera, and then we have PET-CT, and then PET MRI. So coming to my topic, that is radionuclide imaging, and they are broadly classified under three categories, like radio tracer having used for skeletal imaging, tumor non-specific imaging agent, and tumor specific imaging agent. Among the among the skeletal imaging radio tracer, we have MDP, which is bone scan, which is commonly used since many years, and then we have sodium fluoride PET-CT. And coming to the tumor non-specific imaging event, many radio tracer has been tried, and most common among them is F18 fluorocholine, which is still in use, and all other are have not proven so much role in that prostate imaging. Coming to the tumor specific imaging agent, they are gallium PSMA, F18 FDHT, and then F18 PSMA. As of now, till in this present scenario, the most common radiotracer which are used for prostate imaging is gallium PSMA and gallium fluorine PSMA. So these are the two commonly used other than the bone scan. So where the bone scan is indicated in prostate cancer, it is used for initial staging of prostate cancer, for metastatic work of the bone scan. It is used for asymptomatic. It can be used in it is used in asymptomatic patient with PSA level of more than 10. Some guidelines say 20, and Gleason score of more than or equal to 7, and patient having stage equal to or more than stage 2. It can be used in patient those are having symptoms without even high PSA level or Gleason score of more than 6 or less than 6, and with the normal or elevated alkaline phosphatase enzyme. It is used for restaging of patient when treatment is planned. It is used for patient those are planned to be planning to change the treatment, and it is used for the patient those develop bone pain during the process of follow-up. It is used for evaluation of the patient at the stage presenting with pathological fracture during the follow-up. And the last indication of the bone scan is evaluation of the patient before radionuclide therapy, because these patients are here we use the bone scan to assess whether this patient can be treated with palliative therapy or not. This is how the normal bone scan look like. The left two images, as we can say, the symmetrical diffuse uptake in the bone. Everybody knows about that. And there is on the right side we can see there are interior and posterior images. There are focal uptake. These are the images which they are metastatic. That's how the metastatic look like. So coming to the next investigation, that is sodium fluoride PET CT. Sodium fluoride PET CT is actually counterpart of bone scan. As we can see, the difference is that sodium fluoride PET CT is done under the PET and have better resolution and have high target to background ratio, and it is more sensitive as compared to the bone scan. But both of these modality has one advantage, that they are low specificity because of high sensitivity, because they even are positive in benign diseases. According to NCCN guideline, sodium fluoride PET can be used at staging, but according to European guideline, they said it is not so useful because of high specificity, because of the less specificity. This is how, as this is the middle image where we can see there are multiple metastases on the fluoride PET scan, and this is spur scan on the fluoride PET CT on the right side. This is actually super scan type of. This is how the fluoride PET CT look like. Coming to the next investigation, that is FDG PET CT. FDG PET CT, we have used it for prostate cancer management or metastatic workup, but due to the availability of the PSMA, this is almost obsolete now. We are not using it because of the low sensitivity. There is only one situation where still we are considering FDG PET CT, that is when the PSMA is negative and the patient has high Gleason score, where this modality can help in selection of the patient, but this indication is still under trial. This is not yet proven. Coming to the important investigation, that is PSMA PET CT. We all know PSMA is the ideal target for prostate cancer. It is overexpressed in prostate cancer. It is more overexpressed in metastatic castration-resistant prostate cancer. The advantage with PSMA PET CT is that there is no flare phenomena, which we can see on bone scan on the CT images. Now coming to the PSMA targets, there are many PSMA targets, many has been investigated, many has been tried, many has been enrolled in the research purpose, but the most common and the commonly used and the most effective one are gallium PSMA and fluorine PSMA. These are the two logical, I will say these are the only two have clinical impact till date. They are in clinical practice and they are only used, all other are still not matchable. Coming to the indication of PSMA PET CT, it can be used for localization and staging. There is one study which was published in Journal of Nuclear Medicine in 2016. They have shown that the sensitivity of gallium PET CT is almost equal to the morphological imaging like CT and MRI, that is 97% as compared to 99%, and the specificity is 78%, which is far better than the conventional imaging, that is 27%, and diagnostic accuracy is 90%, which is better than the MRI and the other conventional imaging, that is 72%. The next important role of PSMA PET CT is detection of disease in patient. Those are biochemical relapse. Like many studies have shown that it is superior to C11 choline and other imaging modality in detecting biochemical relapse. The other, coming to the next indication of PSMA PET CT is lymph node recurrence detection. It can detect even small node up to the size of 5 mm, but we can miss the lymph node which are less than 5 centimeters. That's where the PET CT, PSMA PET CTs have high false negativity. According to the European guideline, they recommend the PSMA use or choline use if the PSMA level is more than or equal to 1 nanogram per ml in patient those are having a radical prostatectomy in past. They have observed that as the PSA level rises, the detection rate of PSMA PET CT increases. Like we can see from this table, when the PSMA was 0.2 to 0.5, the detection rate was 57.9. But when the PSA was more than 2, the detection rate was 96.8. As PSA rises, the detection rate also increases with rising the PSA level. So this is the flow chart. They concluded that flow chart can be used, PSMA flow chart can be used for the management of the prostate cancer, particularly patient those are having biochemical recurrence or relapse. Here PSMA PET CT can help in detection of local recurrence where it can find unsuspected site. It help in planning radiotherapy. It help in excluding distant metastasis. In oligometastatic recurrence, it can help in nodal recurrence detection. Like nodal detection, it help in planning the surgery, depicting a typical chain of lymph node involvement. It help in excluding distant metastasis. In detecting distant metastasis, it can help in planning MDTT, determining the precise extension of the disease. And for polymetastatic recurrence, it can be used as a baseline parameter for response assessment. And with the help of this, we can see theranostic selection for the patient if we do the PSMA in these patients. So,
Dr. Shamim, you have little time left. Can you wind up, please?
Yeah, sure. According to NCCN guideline, choline is still the preferred investigation because in US PSMA has come very late. But according to European guideline, it is used for detection of recurrence. And in future, I think PET MR will be the imaging which can be of use and which can be a one-stop imaging modality. It will help in T-staging as well as nodal and distant metastatic disease. But the disadvantage with the MRI is that it is time-consuming. One patient can take 1 hour, and it is expensive modality and not easily available everywhere. Now, coming to the second part of the talk, that is radionuclide therapy in prostate cancer. There are many radionuclide therapy has been tried in the prostate cancer, but most common used radionuclide therapies are beta therapy and alpha therapy. Among the beta therapy, we have lutetium PSMA, and among the alpha therapy, we have actinium and radium. The difference between alpha and beta is that alpha has long range, so they miss the target sometime. They can destroy the surrounding tissue. Like in this case, we can say that it is going out of the target tissue and they deposit low energy to the target tissue and have moderate treatment effect. As compared to the beta, the alpha have concentrated delivery of the radiation. They have short range, they destroy the target tissue, and they have excellent treatment as compared to the alpha radiotracers. There is a publication in New England Journal of Medicine where they assess the alpha emitter radium-223 efficacy for the treatment of metastatic prostate cancer. Those were castrated resistant. They found that their overall survival has 14 months as compared to the 11 months in the placebo group. This is the coming to the lutetium PSMA therapy. In lutetium PSMA therapy, many studies, many investigator has investigated efficacy and and dosimetry and all other aspects. They concluded that PSMA therapy reduces PSMA more than 50% in 44% of the patient, and 29% of the patient has objective response, and they have calculated a median overall survival of 14 months. So in our AIMS experience, we have done 125 patient of castrator-resistant prostate cancer. Out of this 125, we have given 400 cycles of therapy, and we concluded that it reduces the PSMA level in significant number of population and has shown partial response in 23% of the patient and stable disease in 54% of the patient, while there was progressive disease seen in 23% of the patient. This is the example of the patient where the patient on the left side, this patient underwent, this patient was a prostate cancer, which was resistant to all therapies. This patient underwent gallium PSMA, and gallium PSMA, as we can see, there are multiple metastatic lesions. On giving the lutetium therapy, the patient has responded very well to the therapy. Only there was one lesion left, which was on D4 vertebra. The patient has responded very well to the therapy. There are many clinical trials which are going through. I'm concluding that. There is a many clinical trials which are going through that. And coming to the alpha therapy, which is actinium PSMA therapy, we have done 28 patients till now. There was more than 50% decline in the PSMA was observed in 39% patient at the end of the treatment. We saw 63.6% response according to the RECIST criteria. This is the patient having the PSMA positive, and we have given this is the complete response to the therapy.
You overextended your time, please.
You have to wind up, please.
Okay, sir. Thank you. I had concluded.
So, Professor P.V. Singh, please to invite the next.
Yeah. I think the time has come when the cancer treatment will go on the molecular level. And this evening, we have Dr. Anuradha Chowgule. She is professor and scientist at Tata Memorial Hospital in Molecular Laboratory. And may I invite her to give a talk on molecular pathology before systemic treatment? What is feasible? Dr. Anuradha, please.
Yeah. Can I share my slides? Can you give me the opportunity to share the slides? Yes. Yes. Let me have my own slides presentation.
We are not able to see your slides.
Yeah. Can you see it?
Just coming, I think it will. Yeah, now we can see. Thank you.
Yeah. So,
full screen, please.
Full screen. Yeah, I'll do the full screen. Yes. Thank you so much. Thank you, Dr. Rajiv Sood, giving me this opportunity to present on the molecular pathology in prostate cancer. So, first of all, molecular pathology plays an important role in establishing predictive biomarkers in tumor, either in tumor tissue or nowadays in the liquid biopsy also you can use it. And today this has become, because of high throughput sequencing techniques, like we are able to build the molecular landscape of primary or metastatic precision cancer. So I'll be giving you the overview of what is feasible to do in the molecular biomarker. So this was a 2016 versus 2004 WHO classification. The only difference in 2016 was that they added the intraductal carcinoma under glandular neoplasms. Rest remains the same as per 2004 WHO classification. And under neuroendocrine tumors, you can see on the large cell neuroendocrine carcinoma has been added and has been classified separately as compared to 2004 WHO classification. And again, you all know this is the Gleason's classification, where you can from group 1 to group 5, depending upon the Gleason score, it has been separated as per the score. Like if the less than 6, you can group into group 1, and the last one I can say is that in the group 5, where the Gleason score is more than 9 to 10, where there is a lacking gland formation with or without, which is poorly formed or fused or cerebrally formed glands, they all come under the grade 5. So this new classification recommends the recently developed prostate cancer grade grouping with 5 grade groups. So this is the actually conventional molecular progression model. As you can see over here, from normal to when it enters into atrophy, you can see there is a P10 loss, NKX31 loss, 0.1 loss, and there is a downregulation of glutathione S transferase P1. Whereas when it enters into the PIN, you can see there is telomerase activity, there is a RB1 loss, P27 down regulation is there, and also you can see the down regulation of RAS F1A, which is the gene where it gets down regulated. Where it is, you can see both these markers either in the PIN or in the invasive. And when it enters in the metastasis, you definitely get to see the P53 mutation or the loss of P53 mutation or gain of P53 mutation. Also, you can get to see the loss of E-cadherin or the androgen receptors independence. So, here is the phenotypic and microenvironmental. How does it get marched past? You can see over here when it from normal, when it enters the PIA, there is a process. You get to see the under this process of oxidative stress, inflammation, luminal and basal proliferation, and in the molecular changes, you get to see the upregulation of BCL2 and GSTP1. Whereas there is the downregulation of NKX3, P10, and CDKN1B. But when it enters from PIA, when it enters to PIN, you can see the processes of luminal cell hyperproliferation, telomere shortening, and there is a stromal reactivity. In the molecular changes, you get to see the ETS transcription factor dysregulation. You get to, and again you get to see the loss of NKX3 and SPOP mutation and a fusion of TMPRRS2 with the ERG. When it enters into the cancer, like in the malignant cell, in this process, the luminal cell hyperproliferation, loss of basal epithelia, there is a basement membrane breakdown, immune cell infiltration, and a reactive stroma. Again, in the molecular changes, you get to see the telomerase activation, P10 deletion, and RB1 loss. So what are the oncogene driver mutations you get to see? Like you get to see the fusion of, as I mentioned earlier, TMPRRS to ETS fusion. And these fusions are seen in most of the, half of all prostate cancers. Coming to the big overexpression, yes, it gets upregulated in early prostate cancer. And there is a, and its locus is frequently amplified in advanced cancer. Coming to telomerase activation, as I mentioned earlier, the protection of chromosome ends by inappropriate activation of telomerase, and it prevents the replicative senescence in highly proliferative cancer cells. Interleukin 6 addiction, you get to see the inflammation. This inflammation causes upregulation of both interleukin 6R and oncostatin M, and an ILK signal transducer. And lastly, you get to see the transformation through enhanced STAT3 activation and associated downstream of gene expression. Coming to the tumor suppressor gene, you get to see the P10 deletion, you get to see the CDKN1B deletion, NKX3 deletions, SPO mutation, and CHD1 deletion. And CHD1 is commonly deleted in primary tumors and often coincides with the SPOP mutation and is mutually exclusive from the fusion of TMPRSS2 ERG fusion. And this protein is involved in chromatin modeling. So what are the genetic genomic profiles of this prostate cancer? You can see somatic copy number aberrations are found in more than 90% of all prostate cancers. Deletions are mostly seen on the chromosome 6q, 8p, 10q, and 13q, and it includes genes such as NKX3, P10, BRCA1, BRCA2, and RB1. And in the castration-resistant prostate cancer, CRPC, you get to see the frequent amplification of chromosome X, 7, 8q, and 9q, which includes the androgen receptor AR and MYC oncogene. In the structural aberration also, you get to see more than 50% of tumors which are involved in this fusion, that is MPRSS2 and ERG, where the ERG oncogene is placed under the control of androgen responsive, that is the TMPRSS2 regulatory element. There are certain rearrangements also you can see in the new, as in the form of new fusion proteins, that is ESRP1, CRAF, as well as the rearrangements involving other ETS family members and RAF kinase gene fusion. Coming to the MSH2 and MSH6, which are the DNA mismatch repair enzyme, these rearrangements are associated with loss of protein expression and MSI, and they are the major mechanism. Has the major mechanism underlying the hypermutation in advanced prostate cancer. Again, as I mentioned, TP53, P10, RBM1, PIK3CA are recurrently altered in treatment-resistant prostate cancer, and activating mutations of KRAS and BRAF is also observed. And there is a recurrent mutations involved in AR and AR pathways. The TCGA Research Network recently presented a comprehensive analysis of around 300 plus prostate tumors, and they identified 7 molecular subtypes based on the genomic profile performed. So what are these genomic profile performed? That, as you can see over here, that the primary prostate cancers can be classified into those with the rearrangements in ETS family, and ETS family transcription factors like ERK, ETV1, ETV4, and FLI1, where it is positive, and those without ETS rearrangements, that is the ETS negative one. ETS positive prostate cancers are classified by the specific ETS fusion genes, namely involved in the ERK, ETV1, ETV4, or FL1. And those which are the ETS negative prostate cancers are classified by the mutations in SPOP, FOXA1, and IDH1, where they are present in very marginal amount. So what is the relationship between the genomic alterations identified in localized and advanced in prostate cancer? So let us say 50% of both primary and advanced prostate cancers harbor ERK gene, and primary prostate cancer without ERK rearrangement can be subclassified on the basis of SPI and K1 overexpression. SPOP mutations can select SCNAs, which are often mutually exclusive. And in the advanced stage prostate cancer, nearly all of them have amplification or mutation of AR or abnormalities of androgen receptors pathway component. Okay. So alterations, as you can see, it has been shown that there are potentially actionable mutations in 25% of cases in PIK3CA MAPK kinase pathways, and almost 20% alterations in DNA damage repair genes. So in the advanced prostate cancer, you get to see more of alteration in the DNA damage repair genes. So let us coming to the hereditary cancer syndromes and prostate cancer. As you can see over here in the under the hereditary cancer syndrome, it is the HOXB13 and the BRCA1, BRCA2, and Lynch syndrome MMR genes need to be detected. And considerations and implications for genetic testings are inherited in these biomarkers, which are having a high risk like HPC, HBOC, or LS, and they engage the patients in decision making, pre-post test genetic counseling, and interpretation of tests, the ethical implications. All these are to be taken into consideration. So men from families with hereditary cancer syndromes include HPC, hereditary breast and ovarian cancer, and Lynch syndrome, which are associated with defects in HOXB13, BRCA1, BRCA2, and DNA mismatch repair gene, respectively. So frequency of these pathogenic germline alteration in DDR genes and in genes associated with hereditary cancer syndromes are also to be detected in the metastatic prostate cancer. So you can see in the germline mutation BRCA2, you can see observe in the younger onset, higher T stage, higher Gleason score, more LN involvement, shorter PSA survival, and overall survival. Whereas BRCA2 or BRCA1 or ATM, you get to see 4-fold higher risk, lethal PCA, and the shorter in overall survival. So BRCA1 has a higher recurrence rate, shorter than the PCA specific survival. So in the heritability of prostate cancer, like you need to look for the Nordic twin study, 57% of the heritability for PCA, and only melanoma has a higher heritability, around 58%.
Anuradha,
yeah.
Can you be a little bit more brief?
Yeah, sure. I'll just skip the slide where they've shown a higher risk of developing the mutated gene, which I've earlier mentioned, that BRCA1, BRCA2, ATM, CHEK2, and NPM, PALP2. So this is the DNA where you get to see the 23% of metastatic CRPCs harbor DNA repair alterations, and this frequency of this DNA repair also increases with the disease progression. So these are, I'll skip this slide. So mainly, I would like to point here, there are the commercially available genetic assays based on the somatic mutation within the prostate cancer, and many of them, one of them, a popular one is the Oncotype DX and the Prolaris. The another one which needs for determined repeat biopsy, you can use the Prognosis, that is PCA3, and My Prostate, the scope. So coming to the targeted therapy, as you can see over here, ARSI, androgen receptor signaling pathways, are involved in the PARP inhibitor. You can see the patient harboring DDR gene aberrations, ATM, CHEK2, BRCA1 and BRCA2, and ICI, that is patient which are harboring MMR deficiency. You can have the treatment for that. And other targets are like anti-adenosine A2A receptor. I won't go much into the detail of it. So these are my last two slides over here. Now, liquid biopsy has also been taken into consideration monitoring the disease. So these molecular alterations can be very well observed, including the HRR and AR aberrations, which are associated with the high efficacy. Then detection of AR gain is also, you can very well detect in through the liquid biopsy. And HRR gene mutations are highly detected in plasma and is highly correlated with the detection of these mutations in molecular analysis of biopsy tissue type from metastasis. This is one of the study where they have correlated with that with the olaparib. You can very well monitor the CFD and the concentration falls after 8 weeks of olaparib, and they correlated with the both prolonged progression-free survival and the overall survival. So this is I won't go into the detail of it of the NCCN guidelines, but here they just show the how to identify, differentiate between the germline and the somatic mutants, how to go into detail about it. So to take home my message that all men with the prostatic cancer should undergo comprehensive gene panel testing to help determine the precision therapy or clinical trial eligibility, and men who have a family history suggest that hereditary prostate cancer, such as men diagnosed with prostate cancer at young age and who died from prostate cancer, or has a strong family history suggestive of hereditary cancer syndrome, such as hereditary breast or the ovarian cancer or the Lynch syndrome. The following genes should be endorsed for the testing, like BRCA1, BRCA2, DNA mismatch repair genes in men with metastatic prostate cancer, BRCA2 among men with non-metastatic disease, particular to inform active surveillance, and BRCA2 HOXB13 among men who do not have a diagnosis of prostate cancer but fit the family history criteria for prostate screening cancer. And any additional genes based on their personal or family history also can be included. Thank you so much.
Thank you, Dr. Anuradha. This is short of time, so I hand over to Dr. Sameer Khanna, my next co-chairman.
Yeah.
Thank you. So it was a very lucid description to the panel of urologists. So we'll move forward to the next topic. Recently, in the past years, immune checkpoint inhibitors have proven to be, very helpful in metastatic RCC and metastatic bladder cancers. So, what is the role of immune checkpoint blockade for prostate cancer? Speaking on this will be Dr. Ranjit Sahu. He is an associate professor in the Department of Medical Oncology.
Can you take away your slides, please?
At IRCH AIMS, New Delhi. So, Dr. Sahu?
Yeah, I'm there.
Yeah.
Okay. So,
so you can just enlighten us about this.
Yes. So, are my slides visible and I am audible and visible both?
Yes.
Yeah.
You can proceed.
Yeah. So, I do not have any conflicts to this presentation. So, now I'm sorry. Yeah. Prostate cancer is a very, over last many ages, we are only one hallmark, that is, it is a hormonally dependent this thing, and we only target that, be it chemotherapy, be it androgen deprivation therapy. They are mainly concerned about decreasing the hormones, that is the testosterone. Now, apart from prostate cancer, there are many cancers, there are other hallmarks, and escaping immune destruction of the cancer cells is a very important thing to happen. Now, over the last few years, now we are concentrating upon two hallmarks in prostate cancer. One is concentrating on the genome instability and mutation, which you could do by PARP inhibitors, which had been discussed by the previous talks. Now, my talk is concerned about how to get above this avoiding immune destruction, which is an important and current hallmark of cancer, how much it is relevant in the context of prostate cancer. Now, this is the best study to quote. I mean, we know that prostate cancer can be halted by some form of immunotherapy, and sipuleucel is the best example. Now, even though the PSA response has not been there, it has shown that there is a good progression-free benefit, which could be clinically meaningful in a subset of patients. Now, immunotherapy is the fifth pillar of cancer treatment. To basically understand what is, I'm sorry, they are moving on it, so yeah. To understand the basics of immunotherapy, we have to understand whenever there is a tumor, your inflammatory cells, they will come around it and try to kill it to make a balance. And you could see they are termed as TILs. Now, in a study that I have quoted this picture, when you have given some sort of immunotherapy, which is ipilimumab, which is a CTLA-4 inhibitor, with ADT for a patient who have underwent surgery, you could see in this picture. Now, those patients who had not received any sort of ADT or immunotherapy, they had a lesser tumor infiltrating lymphocytes as compared to ADT alone or in combination to ADT and ipilimumab. In the combination, these immunoinfiltrates, they have certainly increased. So these drugs have definitely got a role, but there are hindrances. Now, this is the phase 3 study of ipilimumab in metastatic CRPC. Now, in phase 2 study, it had shown that it could be beneficial, but in this phase 3 study, it is clearly doesn't look to provide a benefit. So I'll stop it here. Now, this is the most interesting study which has got recently published in JCO in this year only, where they have used the other checkpoint inhibitor, that is pembrolizumab, in metastatic CRPC. Now, they have chosen 3 cohorts. I mean, we know that those patients who have this PD-L1 expression, they may be benefiting from this immunotherapy, though it is not a very good biomarker, but that is the best possibly we have till this day in other cancers. Now, they had 2, especially 3 cohorts. One cohort was those cohort which was PD-L1 positive. The second one, a cohort which is PD-L1 negative. The third cohort was bone predominant disease, because in preclinical studies, it had been shown that those patients who had a bone predominant disease, they are more amenable to immunotherapy. So let's look into the patient cohort. When you look into the PD-L1 positive and PD-L1 negative cohort, it appears that they are essentially similar, with a higher percentage of visceral disease in those patients who are PD-L1 positive. Now, when you look into the response rates, in PD-L1 positive, the response rate is only 5%. In PD-L1 negative, it is not far low, it is 3%, it is as miserable. Possibly there had been no responses in bone predominant in the cohort 3. When you look into the disease control rate, I mean the stabilization of disease, it is close to 10% in either of the cohorts. In the third cohort, that is the bone predominant disease, it is close to 20%. So the thing is, if we look into a biomarker and we take PD-L1 as a biomarker, it might not serve you well to select those patients who could actually benefit from immunotherapy. Now, just look into the duration of response. If a patient develops a response to this immunotherapy, the duration could be as high as 10.6 months. Now, let's go to the next biomarker. Now, this immunotherapy, they had got a tumor agnostic approval. Those patients who have any tumor who has got MSI high or high tumor mutation burden, they could benefit from immunotherapy, whatever the site could be it lung or head, neck or whatever. Now, the incidence of MSI high tumors, now Dr. Chogle had softly dealt with it. It is unclear in prostate cancer. It could be varying from 1 to 10%. But the recent sequencing studies with respect to the TMB, when they have evaluated, it is close to 2 to 3%. And most of them are often MSI high or deficient MMR. And it was also found in the longitudinal analysis that many of these MSIs are actually acquired over the process. Now, today, when we diagnose a patient of prostate cancer, he could be negative, but he could be positive subsequently. Now, this had been the maximum data, maximum information about using the checkpoint inhibitors in those patients who have got MSI high prostate cancer. Now, this is only included only 11 patients, and the response rate is close to 45%. As many patients, they didn't respond, and the stabilization of disease is close to 10%. So it is a useful drug in those patients who have prostate cancer and have MSI high. So it is a sort of a good biomarker beyond the PDL1. Now, MSI is possibly not enough. I mean, it doesn't tell you who are the patients who are going to actually absolutely benefit from this approach. Now, this had been from a preclinical study. They have looked into CDK. Now, when CDK is inactivated, especially CDK12, when it is inactivated in prostate cancer, now Dr. Chogle had actually touched on everything. This is still pretty recent. This was not mentioned in a talk. Yeah, so it is a mutually exclusive mutation, mutually exclusive genetic abnormality, which is exclusive to the TS fusions, which she had told, SPOP, HRD, ATM mutations, and mismatched DNA mutations. As you could see in this picture, those who have got CDK12, they have got a very different expression profile as compared to the others. Now, the second thing is, it also correlates with high number of differential genes as seen in this picture. If you see this blue colored line here, it pertains to CDK12. So it has got the maximum amount of tumor neoantigens. It means that it has got a maximum amount of tumor neoantigens. When the tumor neoantigens are high, possibly these are the patients which are going to have a maximum benefit from immunotherapy. Now, this had been very, limited data about usage of immunotherapy in those patients who had got CDK12 inactivation. Now, as you could see in this picture, the nodal size has definitely decreased, okay, in the CT scan. Now, when you look into the pathology, these green colored dots, I'm not sure it is, they are brown colored. So these brown colored dots have actually increased. This is pre-checkpoint inhibitor, this is post-checkpoint inhibitor. So in pre also, there is a good amount of CD3 positive T cells. I mean, they are immunologically mediated tumors. And with nivolumab, when the node has actually decreased, when a biopsy is done, the amount of CD3 cells, possibly CD8 mostly they are CD8, they have actually increased. So as of today, there is no data about usage of anti-PD-1 inhibitors in those patients who have CDK12 inactivated CF prostate, but it remains a very promising biomarker. It requires to be seen in the future. Now, the next approach is, we know that immunotherapy is a miserable drug in CF prostate cancer. So can we also use it in addition to anti-angiogenic agents? Just like in metastatic RCC, something like pembrolizumab, axitinib. Now here, a PDL1 agent is combined with cabozantinib, and you could look into the overall response rate. This is metastatic CRPC patient post multiple lines. The response rate had actually increased to 30%. So if I may conclude my talk. So prostate cancer is a non-immunogenic tumor. We require to identify patients who is going to benefit from immunotherapy. Now PDL1 is a measurable marker. MSI high patients or TMB, they are somewhat pretty close to be a good biomarker. Now CDK12, in my opinion, it is going to be the next generation biomarker to choose the patients who are going to benefit from immunotherapy, which is the incidence of CDK12 in prostate cancer is close to 7%. And when we come into the drugs, CTLA4 inhibitors, they are clearly ineffective. PDL1 inhibitors, they are effective in a very small subset of patients. But when these patients, they respond, it has got a very good duration of response. Now, the next generation immunotherapeutic agents are either going to be combination strategies, just like adding an anti-angiogenic agents to a PD-1 or PD-L1 inhibitor, just like atezolizumab and cabozantinib, or we may look something more of using nivolumab and ipilimumab in future. So that was my last slide, and I'll be happy to answer a few questions if you have. Thank you.
Amit, take over.
Thank you, Ranjit, for a lucid talk. It is very new to us as we urologists. We are still confused about what hormone to give, and you have put a new perspective to add immune checkpoint blockade in advanced cases. So with this, I think we'll go back to Umesh and conclude the session.
I think before we go to Umesh, can I make is there time for me to make one or two comments?
Yes, sure, sir. Go ahead.
I think the most important thing that we all have to understand is the rapid advancement that's taking place in the area, in this region of urological cancers. I'm not restricting this comment only to prostate cancer, but if you look at bladder cancer, if you look at kidney cancer, even testicular cancer, the amount of advances that are occurring is so fast and numerous that probably poor urologists cannot keep pace with all these advances that are occurring. I think it is necessary also for us to understand how much are these advances going to be beneficial for an Indian patient. My concern is not Western. I am not bothered about whether West dies or West lives, but I am concerned about Indians living. How much are these tests beneficial for Indian scenario? We are all talking about so much of drugs, so much of investigation, so much of attitudes, that unfortunately, I think it is not possible for many of these things to be implemented in an average Indian. I'm not talking about the multi-rich. I'm talking about the average financially strapped Indian. How much of these investigations or these available modalities that we have today are going to be beneficial for them? Are we going to be still left with orchidectomy and bicalutamide, or are we going to say more treatment can be implemented? Even if you take, for example, abiraterone, cost has come down. Enzalutamide cost has come down. But what about apalutamide? What about the other newer thing, darolutamide, etc., etc.? How much cost there can be given to our average Indians and keep them going for non-metastatic disease? Now, these are all things that we have to consider. Overall, it's a fantastic program. I don't deny that. We have learned a lot. But the net result ultimately of all this should be how do we manage our patients and what is the best treatment that you can give for a patient with a minimal cost as far as patient is concerned. Thank you, Umesh.
Thank you, sir. Thank you very much for your words, and we'll keep this in mind when we'll organize this in the next coming future. And I would like to thank all the chairpersons and the speakers for this wonderful session. So we are already a little bit late, almost 30 minutes. So for the next session, there is a discussion, there is a debate between adjuvant versus early salvage radiotherapy in an adjuvant setting post prostatectomy. And for this, I would like to invite Dr. S.N. Huku. He is a chairman and senior consultant in radiation oncologist at BLK Hospital, New Delhi. And Dr. Gagan Saini, he is an associate director of radiation oncology, Max Vaishali. So, sir, over to you for this debate. And I'm sorry to say that you have only 15 minutes because we are already running late. Over to you, Dr. S.N. Huku, sir.
So good evening, everybody. We don't have 15 minutes. 15 minutes are for the speakers.
Yes,
and we are running late.
Dr. Prashant is not available. I think Dr. Gagan Saini is the only who is going to give the talk.
Sorry?
Dr. Prashant Dadankar, he is not available for the talk. And Dr. Gagan Saini is the one who is going to give the talk. So the discussion is
part of the hero and heroine both, or he will only play one part?
You are only
debate.
Dr. Gagan Saini and Dr. You people.
Who is coming first?
Sir, Dr. Gagan Saini.
Prasad is not there. Prasad had to. Prasad was busy with some family commitment. Really couldn't be here.
Prasad was to speak on adjuvant radiation. And
So I will be speaking on, I will be taking this as a topic. I will not be taking this as a debate.
Okay, thank you, sir. Go ahead, sir.
Should I start, sir? Dr.
Yeah,
Upu? Please. Good evening, everyone. Very late good evening. And I appreciate the stamina of all those who are still here. You know, I myself got a little, I'm a little tired now. So as was discussed, you know, Prasad couldn't be here. He had some really pressing family matter. So today I will be, so I got this intimation an hour back. So I have changed my discourse into adjuvant versus early salvage RT. So it's not really a versus. I will be talking about both. I'm Dr. Gagan Saini, and it takes a while for the slides to start moving. So yeah, so cancer prostate is a very heterogeneous disease. You know, all of us are practicing, and you know, so many of you are eminent uro-oncologists. You will appreciate the fact that on the same day you will advise watchful waiting to a patient and maybe discuss chemohormonal therapy with another. So that's the level of heterogeneity this cancer has. This is not really a cancer where you just get away with understanding the loco-regional disease. You really have to understand the biology. And so what does adjuvant radiotherapy mean? I mean, what are the recommendations about adjuvant radiotherapy? This is a screenshot from NCCN, and if I just zoom it up, it says that indications of adjuvant RT include a P-T3 disease, positive margins, or a seminal vesicle involvement. So you may appreciate the fact that these are all loco-regional considerations. These are not biological considerations. And surely, you know, this cancer, prostate cancer, initially started with started as any regular cancer. And over a course of years, we have figured out its biology, we have figured out the nuances of its biology, and of course, the pathology, surgery, and everything has improved. So certainly there is something to build on this argument of adjuvant radiotherapy. So let's start with how does this cancer really behave? This is a recent report where they have reported about the biochemical relapse-free survival rate, you know, how it plays out over the years. And you can see that on the left, it's the entire population, and you will see that how it starts falling, and you know, a good 60-70% are doing well. But here you will see that low risk are the ones who are doing the best with intermediate, and high risk are really dropping off with their biochemical relapse-free survival, where they're almost sure to get a recurrence. This is another paper, a JAMA paper, and you know, talks about how 82% can be free of actuarial metastasis after radical prostatectomy. But then if you see the population, you know, this is definitely of relevance to the urologists, that they are all of good biology with, you know, localized diseases and, you know, low PSAs, and organ confined with less low Gleasons. And even if there is penetration, the Gleasons is less. This is another paper by Stephenson et al. Where he talks about, where they report that the rate of biochemical relapse at 5 years can be 52% if Gleason's is 8, and 74% if Gleason's is as high as 9 or 10. So what I'm actually you know, trying to bring forward is that there is not just a loco-regional concern about T3s or seminal vesicle, while it's very relevant because it is ultimately a loco-regional disease. It's not a hematological disease, so to say. So, but there is also a biology aspect which is playing in form of Gleason's, which is playing in form of PSA. So this is, so I'll start talking about how adjuvant RT is faring. So this is the SWOG 8794 study. Some people call it the believer study. T3 N0 patients, extracapsular extension with seminal vesicle invasion, node negative. 400 odd patients, RT given to prostatic bed, 60 to 64 gray. And primary endpoint is metastasis-free survival. So they have a median follow-up of about 13-15 years for different endpoints, which is a very robust follow-up. And they have reported that there is a benefit when you're doing adjuvant RT in comparison to observation arms. And this benefit gets played up in seminal vesicle positive patients where adjuvant RT is statistically significantly superior up to the point where the last patient is surviving at 12 years. And here is the local recurrence-free survival, and you know, even that is statistically significantly better. here is the hormone-free survival, which is a very important endpoint, by the way, because, you know, after so many years, what is important is that how good a quality of life the patient is getting. And here is the overall survival. Even the overall survival, it's making a difference. So that's really a very, very good study, and it's called not called a believer study for nothing. Then this is a FIN prostate group trial, which had T2N0s and T3N0s with or without positive margin. And then there was Gleason's all Gleason's were allowed, and PSA was high, and post-op PSA had to be less than 0.5. So there they found that the benefit only came in the biochemical recurrence-free survival with no benefit in overall survival. They also had a 10-year follow-up. Then this is the ARO 9602 AU AP study. PT3 PN0 undetectable PSA post-Radprost, and they found a progression-free survival benefit which was statistically significant. But and also this is the local regional recurrence-free survival. And in subcategories, they found that this rhomboid was always towards the left. So, you know, just as a brush up, this rhomboid has the confidence limits. And if the confidence limits are on this side of the unity, then it is a statistically significant result. That is why the rhomboid has to be on this side. And on that note only, you can see the individual populations of this PSA less than 10 are actually touching unity. You know, these are the kind of cases, situations where you may like to hypothesize that these are not the populations which are benefit. You may like to hypothesize, I said. This is not a conclusion because this is not the primary endpoint. The primary endpoint was about biochemical relapse-free survival. This is the URTC trial 22911, PT3N0M0, capsule perforation, margins positive. And they found that giving radiation led to improvement in biochemical relapse-free survival and clinical progression-free survival as well. So good. And the benefit was seen in low, intermediate, and high-risk groups. And irradiation was better in all three arms. Again, the rhomboid is here. And even in all the subcategories, the irradiation was better. So far so good. You know, adjuvant RT is really making a good play for correctness, and sure enough, that is why it is not just given in the NCCN guidelines. It is also there in the AUA and Astro and ASCO, and everyone endorses it. It's like everybody's concurring. So but then is there any merit in delaying adjuvant RT? Now comes the other side of this thing and the debate part of it. I'm not going to be debating it. As I said, this is not a debate anymore. I'm taking it as a topic. So what is the merit in delaying adjuvant RT? Now, why would you delay anything that is adjuvant and is required? And you have seen that it has been benefiting consistently in all these patients, in some of them even having, in one of them even having a survival benefit. That therein comes the understanding of the other part of the debate, which is the early salvage RT. Now that is a separate concept in itself. What is early salvage RT? Early salvage RT is when you are putting the patients in observation. You may notice that all the second arms in the previous trials, every one of them had an observation arm. So you go in that arm, you take the patients for early salvage, as in you are very, very receptive to the increase in PSA, and you put the patient up for salvage very, very quickly. Now, what all those parameters are, I will be coming in the future slide, but I'm just kind of cutting it fine for you to make you understand that early salvage is not adjuvant, because adjuvant is like when you decide on the histopath report, you read the histopath report, you say, okay, fine, these parameters are getting fulfilled, patient goes for adjuvant, patient gets adjuvant. You read the histopath report, you understand the risk factors, but still you may choose to put the patient on follow-up. When I use the word may choose the patient, there are two aspects to it. Of course, if you want to practice early salvage, that is the first aspect to it. Second is whether the patient actually deserves early salvage. This is the second and important aspect of it as well. So if you choose the patient to put on early salvage, then you have to be very, very proactive and understand that, you have to initiate RT at the smallest drop of a hat. And that's where we will be building. But let me first go back to the trials of adjuvant radiotherapy, which is very important from this point onwards. This is a critical review published in 2015 of all the previous trials that I have talked about. They were all randomized trials. There were some issues in these trials. they only investigate the role of adjuvant RT, whereas second line of treatment, that is early salvage, has been as a philosophy existing in the world of uro-oncology for a while, and they failed to resolve this crucial dilemma. Most importantly, many patients had a detectable PSA at the time of randomization. Therefore, they were actually receiving salvage RT instead of adjuvant RT, and thereby it muddles the results. RT dose was low in many trials as per current standards. And for each gray increase, there is approximately a 2.5% improvement in 5-year biochemical relapse-free survival. So certainly this increased grays are very, very important. It's not like they are not. And yeah, right. In the comparator arm, the treatments were uncontrolled, as in they were not well defined. And that is, as I said, the comparator arms are the ones which are going to have an early salvage, but they were uncontrolled. The patients were treated with several options. They were not treated with one option, or they were standardized option or standardized PSA related guidelines. The SRT at PSA was given at 1 nanogram per ml consistently, which is very high. What I'm saying is salvage RT, SRT is salvage RT, was given at high PSAs. So that is where the comparator arm and even the primary arm are kind of getting muddled, and that is where this thing comes in. So let's see the recent data on early salvage. This is the Radicals RT trial. This was presented in abstract form in the recent ESMO meeting, and it has not been published, so this is it. So they took post-radical prostatectomy patients. Post-op PSA were less than 0.2 nanogram per ml, and they had to be 4 to 22 weeks post-op. One or more of the following factors had to be there, that is PT3/4, Gleason 7 to 10, or a pre-op PSA of more than 10 nanograms and positive margins. By the way, these were also stratified. So this is stratified into the trial design. And then they were randomized. So you have all these criteria where you could go in for radiation therapy, but then you randomized. You randomize them into radiotherapy, that is adjuvant, and then you randomize them into salvage RT. So this is no more an observation arm. Observation arm is a very ill-defined arm. What are you observing and what are you going to do when you are observing it? And that is what happens in clinics, by the way. People continue to observe, and the PSA crosses 1 nanogram per ml, and then the situation becomes unsalvageable. So, this particular box, this lilac colored box, is a very, very important box for anyone who is willing to practice early salvage. Please understand that the threshold for salvage RT is 2 consecutive rises and a PSA of just 0.1 nanogram per ml. So you've got to have 2 consecutive rises, and with a PSA of greater than 0.1 nanogram per ml, you are set for initiating the patient into radiotherapy, or 3 consecutive rises regardless of the PSA level. So what is very important, what I'm trying to highlight here is that if you're choosing to not give adjuvant RT to the patient, this is the methodology to be followed. This is a very diligent methodology, razor sharp. And this is the outcome measures. Their primary outcome measure is the freedom from distant metastasis, and the secondary was biochemical progression-free survival. And their populations were well balanced. So you can see that in this arm, the adjuvant RT arm, everybody is going to get RT because they are randomized. So 7% only have not received it. And in the salvage RT arm, they are gradually building up, over 6-8 years. About 30% have received salvage RT. And now this 2 bar diagrams. This is the salvage RT, this is the adjuvant RT. So you can see that a large number of patients haven't still received RT. Some of them have received RT. Here, of course, everyone has received RT. Some of them have also received hormonal therapy. Okay, the results. The biochemical progression-free survival is same in both the arms. This is at 8 years. It is not statistically significantly different. Of course, you can see it with the graphs as well. They're all mixing into each other, so it's definitely not significant. Initiation of non-protocol hormonal therapy. I did say that a minute back, that non-protocol hormonal therapy is very important because, that's when you declare the patient to be, out of the bounds of adjuvant treatment, out of the bounds of cure, and then you start treating them on hormonal therapy. And this is also not statistically significantly different in both the arms. This is good. They could not, 26 events have only happened till now, and further follow-up is needed to talk about survival. And this is about the safety urinary. So this particular slide is about the urinary toxicity. The reds are in the adjuvant and blues are in salvage. You can imagine, they put red in our adjuvant. Here you can see for cystitis, 2% grade 3 cystitis and 0.7% grade 3 cystitis in the salvage. Is 2% grade 3, but it looks like it's a huge, a lot more help. And here it looks like it's quite less, perhaps because of the grades. And here it's 3% versus 0.3% and 4% versus 5%.
Please close.
I had 15 minutes. Have I completed 15 minutes, sir?
Yes, you are in the 16th minute.
Oh, okay. So I'll just close now. I didn't realize that. So this is about the safety, GI safety, higher in adjuvant as expected, patient-reported outcomes. Summary and conclusion, they said that you could, cut down on adjuvant RT. This is artistic meta-analysis. They meta-analyzed 3 trials. This is radicals, K2GFU, RAISE trial. And in all these 3 trials, similar kind of cut points were there, which I just, dwelled upon in the radicals trial. And they found that the adjuvant RT and salvage RT were quite similar to each other. And they said only 1% difference is there. So I will just take 30 seconds on this slide, which is the crux of it, sir. The conclusion. So adjuvant RT is a standard practice. So please practice adjuvant RT when you are having a standard practice, when not an institutional practice. Standard practice as in, follow-ups are, maybe not dedicated clinics and other things where you really cannot monitor the PSAs and other things. But it does have a potential for more side effects, but it's easier to practice in community. There is long follow-up available, so there is a possibility that we will probably be having we probably have a survival benefit with adjuvant RT given in the way it has been advised. And the numbers needed to treat it are 9. For 9 patients you treat, you can save 1 life. This is not a very high number because in breast cancer we treat 21 patients to save 1 life. Salvage RT, razor edge practice. I have dwelled upon it. I also don't have time to go at it again, but you have to be very, very careful. You cannot do a 3 monthly, 4 monthly, or just observe the PSAs going very high, because that's when you will spoil your own outcomes. It cuts down on side effects. Only biochemical relapse-free equivalence has been established at 5 years as per the artistic meta-analysis is concerned. More time is needed, so there is certainly some limit to this particular salvage RT point. Longer follow-up may or may not reveal further benefit. Numbers need to treat are quite low. I would like to thank you, and I especially acknowledge Dr. Prasad Dandekar of Dhirubhai Ambani Hospital. Thank you, Dr. Hupu, and thank you, Dr. Sood.
So thank you, Gagan, for taking up the challenge of speaking on both sides. Now, although the recent PROTECT trial showed that there was no difference in outcomes for localized prostate cancer if you use surgery or radiation, but radical surgery is still a preferred method offered to the patients, especially in big cities and metros. Radiotherapy is the method which is offered to patients for localized prostate cancer in rest of the country. Now, once the patient has undergone surgery, there is an obvious lack of data comparing adjuvant versus salvage radiotherapy. So such debates are always across the departments throughout the world. For adjuvant radiotherapy, there are 3 randomized control trials which have been alluded by Gagan, and all these trials favor adjuvant or early radiation within 4 months of surgery. There are points in favor of both strategies. The proponents of adjuvant radiotherapy say that more than 50% of the high-risk patients will have recurrence post-surgery, and these are the patients who are going for distant metastasis also. And therefore, we should use adjuvant radiotherapy. They also say that the post-operative radiotherapy is the only curative potential left for these patients. So we should introduce radiotherapy as early as possible if the patient has adverse features. The proponents of salvage radiotherapy say that despite 3 randomized control trials, if you look across the clinics, and which I also agree, that adjuvant radiotherapy has not really picked up. If you look at 10 patients who come to your clinic, probably 8 will have salvage radiotherapy and only 2 will have adjuvant radiotherapy. And the reason is that the proponents of salvage radiotherapy say that even if you treat these patients at biochemical failure or local progression, probably the results are the same. And there are large majority of patients, more than 50%, who have adverse features, but still they will not develop recurrence over a period of time. And if you add radiotherapy like an adjuvant in these patients, probably you are over-treating these patients and you end up in having a higher urinary, a higher bowel, and higher sexual complications. Answer to this probably will come from the results of 3 major trials, that is the radicals, which is going on in UK, Ireland, Canada, and Europe, RAVES in New Zealand and Australia, and the French trial. Till then, the department should have their own criteria of selecting patients who should go for adjuvant and who should go for salvage. And some of the important features the department can take into account is one or more than one high risk factors, residual PSA after surgery, and biomarkers. Till then, we should, go on debating, and we should have a protocol in our own department for patients who will go for early as well as salvage radiation. Thank you very much.
Thank you, sir. Thank you very much. And this is a nice debate, and we definitely learn a lot from these 2 discussions. So finally, moving to our last panel discussion, which is being moderated by Dr. Rajiv Sood sir. And for this, I would like to invite the panelists. The debate is on the management of prostate cancer during COVID-19 period. And our panelists are Dr. Amlesh Seth sir, who is the President North Zone USI, and Professor HOD Urology Department, AIMS Delhi. Dr. Bharat Vaswani, he is a Senior Consultant Medical Oncologist, Yashoda Hospital, Hyderabad. Dr. Janak Desai, Chief Uro-Oncologist, Samved Hospital, Ahmedabad. And Dr. Hemant Goyal, he is an Associate Professor and Head of Department at RMN Hospital, New Delhi. So welcome all the panelists, and I request Dr. Sood sir to kindly proceed for the panel discussion. Sir.
Thank you, Umesh. Thank you very much. And with my co-panelists, I'm going to discuss the final part of this masterclass, and this is related to COVID-19 era. We have certain doctors here who have already not only treated in this era, but also suffered in this era. And I'll not name, but myself, I suffered it, and I'm treating also all the patients and still continuing. So without wasting for much time, I'll like to start the presentation, very short presentation.
Dr. Umesh, Dr. Suman Malik is also there. If you can just introduce it.
Okay.
Dr. Suman Malik is from Calcutta, is a radiation oncologist.
From Kolkata, sir.
Yeah.
Sorry.
Yeah. Sorry.
Yeah. Welcome, sir. Welcome.
Thank you. Oh.
Sir, go ahead, sir. Dr. Sood, sir.
Okay. So should I start?
Yes, sir. Yes, sir.
Yes. So with the can you see my slides? Can you see my slides?
Yes, sir. Yes, sir. We can see your slides. Just make it full screen.
Okay. So now I'll straight away start that. Why it is the final slide is coming? Just a minute. 1 second only. So today we have discussed all the aspects of CA prostate, whether it is localized, whether it is advanced, locally advanced, or metastatic, or maybe the terminal stage CA prostate. But this is the COVID era. This is the COVID pandemic going on, and patient journey in the treatment, we all know whether it is localized to the metastatic. All the stages androgen deprivation therapy is there. Why I am mentioning it at upfront? Because we are going to talk about hormone therapy, and hormone therapy is very important for two reasons. One, the low testosterone in our body, they protect us against COVID infection and the severity and also the death rate. These initial studies have already reported. So, right, whether it is localized disease or advanced disease, this is important that we are treating with the androgen deprivation therapy, and also when it is right to commence the hormone therapy. This is basically in the current guidelines in the symptomatic metastatic immediately. In asymptomatic, there are certain conditions where we decide about this, but I'll not deliberate on that. There is a role of androgen deprivation therapy in the localized cancer prostate also. When you are giving external beam radiotherapy, now what is new? Most men with prostate cancer are given hormone therapy and is often effective for some time. In most of the cases, over time, progression occurs and patient goes into metastatic hormone-sensitive prostate cancer and ultimately into the castration resistant. And chartered latitude and stampede trials have been discussed already. And what is the consensus? That if there is a metastasis, we go for docetaxel, but ADT continues. And ADT, I told you, is protecting. But what we should do with the docetaxel in this era, we'll discuss. And also controversy is there when there is low volume disease. In low volume disease also, and in the what is the change? The change is from docetaxel to abiraterone, and that has come in latitude trial. And since 2017, purely hormonal manipulations are working and they are giving good results. And now, to conclude, hormone therapy is highly effective. It is low toxicity treatment, and choice of the drug depends on the cost, local prescribing habits, and in the COVID era, you want less and less patient visits. So straight away, going to the now discussion part, the COVID-19 times, when the patient says that or presents with the symptoms that he is worried that he might be having prostate cancer, and can I see the doctor? Dr. Janak Desai, what you will do when you are suspecting or patient is coming or has been told to get investigated for CA prostate? Dr. Janak, please.
Sir, you need unmute yourself. Unmute yourself, sir.
Okay.
Janak, sir. Dr. Janak, unmute yourself.
Okay, in the meantime, when Dr. Janak is coming, I'll just mention quickly because we are running late also, and Dr. Janak will be giving opinion. So what we do that we are planning for a visit, we give the appointment, but we observe 14 days quarantine period, and that is or the waiting period according to the government policies in those areas where COVID is rampant. And Delhi and some of the cities are there, those areas. And then comes that if the patient is diagnosed with that, we will be discussing whether the surgery is to be offered or the radiation is to be offered or chemotherapy to be offered. Dr. Janak, can you unmute yourself? Yes. So what is your take on the patient is coming this time? What is your strategy that patient is suspecting, how to diagnose, If the patient is already on the treatment, how to follow, and if you are deciding for the localized cancer, that radiation is to be given or surgery is to be given, or maybe the charted trial or other trials are given, upfront chemo is given, or latitude. Yes, Dr. Janak?
Yeah, so I joined a bit late. So is this the question? During COVID times, what is to be done? Is that
Yes,
the
sir. Yes, yes, when the patient suspects.
Surgical point of view.
Right from that point.
No. From what point?
Surgical.
When the patient is suspecting, how he should approach, because the OPDs are affected, the patients are not coming, many places lockdowns are going on, and the transport is also not available. How to deal with this situation when the suspicion of prostate cancer is there?
Well, see, if there is a suspicion of prostate cancer, first of all, I like to do a teleconsultation. Who raised the suspicion? The patient, just because the PSA was whatever 5.5 or something and got afraid, read on Google or whatever, and there was a suspicion, or a local doctor, a local urologist did a PR and there was some on the digital rectal examination, a suspicion, and therefore a suspicion was raised. So on the teleconsultation, I like to be to make sure that this patient definitely needs to be further analyzed. I would like to do a DRE, for example, or I would like to repeat a PSA. By repeating a PSA, if the PSA is going down, I'll reassure the patient. Might do a free PSA, and then that ratio, I'll try to elicit more information, in other words. But finally, the patient has to come to the clinic.
So if the patient is in the PSA range between 4 and you are suspecting by DRE or a high risk patient, the family history or other factors, or the in the normal times opportunistic screening you would have done. So what you do with the patient if the suspicion is there, PSA is between 4 and 10?
Yeah, if the PSA is between 4 and 10, I would, number one, order a free PSA and consider the ratio, which is not always correct, but if the free PSA is more than 20%, I would like to wait. I'll reassure the patient, number one. Number two, I'll do a digital rectal examination, which gives me a rough idea as to any suspicious area on the prostate. That is number two. And number three, I would like to repeat the PSA after a while. I like to repeat, give alpha blocker to the patient. If he's not taking one, make sure that that residual urine is not creating that little bit of minor infection triggering of the PSA. So I'll repeat the PSA after say about 3 or 4 weeks. And if that also is high, then I will start discussing PIRATE scoring, MRI with PIRATE scoring. And if that also is suspicious, well, then finally pull him into a biopsy.
Dr. Janak, then what is the difference between the COVID times and normal times?
Well, for malignancy, you have to be careful when you are dealing with each other. You are wearing a mask. At the most, you will get a COVID test done for the patient. With the reports will come in very quickly. But just because there is COVID and there is cancer, you can't put a blind eye on the cancer aspect. You've got to do something.
Dr. Amlesh is there? He has joined, or Dr. Bharat Vaswani?
Sir, I am here. I am a medical oncologist, sir. Tell me, sir.
Okay. So what is your take on if it is high grade? Now biopsy has been done. Dr. Janak has done the biopsy.
Yes,
And it is high grade tumor and with some metastasis also there. So what is your take on that? How you feel in COVID time?
Sir, so it is a de novo metastatic hormone sensitive prostate cancer.
Yeah.
Sir, the thing is we have two options, either a oral tablet or a IV chemo. So in oral tablet we have two, either abiraterone or enzalutamide, which is available in India. Sir, with all the data, it is there. You have told Charted, Stampede, Latitude, and now there are two, Arachis and Inzamate. Sir, the data suggests that even in high burden disease, these oral tablets are as efficacious as IV chemo. So as far as possible, I avoid IV chemo. Now the option comes whether abiraterone to be given or enzalutamide, and hence also here there is a preference. In abiraterone acetate, you have to give steroids, which may be an immunosuppressant. So for all purposes, whatever new patients I have started in this COVID era in a metastatic hormone-sensitive prostate cancer, I have started my patient on enzalutamide. Now coming to LHRH, whether agonist or antagonist. So probably a depot preparation, which is either a 3 monthly or 6 monthly, I'll be more preferring that. You say Digarelix, which is a pure antagonist, it needs to be given monthly. So difficult for patient to come monthly in this COVID time. So if there is no impending cord compression, that is the only thing, or you are not worried about that androgen flare, we are preferring to start our patient on LHRH agonist. What we are giving is 6 monthly leuprolide of 45 mg. In case of hormone sensitive things, these are the two things that I am doing, sir. In resistance, this is a different thing.
Okay. We are not preferring chemotherapy for certain reasons, that hospital visits are to be avoided. The complications are also to be avoided. It leads to neutropenia. The steroids are to be avoided, as has been very well said. And therefore, this is the situation. And as the Charted trial upfront in the high volume disease, if we are thinking otherwise in normal times, to start with the docetaxel, that also we avoid.
Sir, even in Latitude study, in high burden disease or high volume disease, the benefit of abiraterone was probably as good as docetaxel or probably better. The hazard ratio, if you compare in Charted, it was 0.78, and if you compare in Latitude, it is 0.63. Although there is a cross trial comparison, so our oral tablets are as good even in a high burden also, sir. There is enough data to suggest. So why to take a risk of IV chemo with all neutropenias and everything? It is oral tablets are as good as IV, sir.
So we do the stratification also, and if it is localized, we were talking about high volume and low volume disease, metastatic. But if it is localized, Dr. Hemant, what we'll do, you will offer surgery or radiation?
High risk localized. It is high risk localized, sir.
Yeah.
So, sir, high risk localized, I'll counsel the patient. That is more important. I'll tell him about pros and cons about both about surgery as well as radiotherapy. At this point of time in COVID era, I'll preferably counsel more towards surgery, because that is a 5-day process. In fact, in radiotherapy, he has to be exposed for 5 or 6 weeks. So I'll be biased towards surgery.
The problem is that with the surgery, that if it is surgery is mandatory and there is alternative of radiotherapy, my take is that I present to you that the patient you are giving LHRH agonist as depot preparation 3 monthly, maybe Joladex you are giving, Oserlin, and that will decrease the risk of COVID. That will also improve the outcomes if COVID is contracted, and if you avoid surgery for some time and you start with radiotherapy in that patient after adjuvant, after neoadjuvant hormone therapy, which can be given 3 to 6 months till the COVID era, pandemic is going on, or the high reporting of COVID cases is there, you can tide over that crisis. And there is one view where 11 studies have been, guidelines have been presented, and in that they are discussing that we can postpone and even radiation can be modified. If Dr. Suman Malik is there?
Yeah, I completely agree with you. For prostate cancer now,
actually we are moving towards more hypofractionated radiotherapy, which means less number of fraction, and usually we deliver high dose per fraction, and that can be completed within a week. That stereotactic body radiotherapy is feasible for prostate cancer, and for high risk cases we are delaying the radical therapy by giving neoadjuvant hormone therapy. So instead of 3 months, we can go up to 6 months neoadjuvant hormone therapy, and then we can consider for hypofractionated radiotherapy that we can finish it off within a week time. So it is possible. So by which actually we can reduce the hospital attendance of the patient and reduce the risk of getting COVID infection.
So this is very important that radiation nowadays is, you can delay even radiation with the new adjuvant hormone therapy, and for 3 to 6 months, and when you are giving hypofractionated doses and even the external beam radiotherapy, the less number of 5 to 7 days as the NCC and guidelines you can give to the patient, and you can tide over this time. Now we are talking about the surgery. We are talking about whether the radiotherapy will be offered and what kind of radiotherapy, and what about hormones. Hormones are continued. If you are giving already antagonist, you will like to shift on agonist. Doctor, yeah.
Yes, sir. Actually, nowadays, now we are preferring, as a medical oncologist colleague said, that we are preferring agonists because we can give 6 monthly injections or at least 3 monthly injections for agonists. But for antagonists, we have to give monthly injections. So that's the problem.
Recommended.
Yeah.
Whichever is recommended from antagonist to agonist.
So usually that's why we are favoring the agonist, and we are giving 3 monthly injection of LHRH agonist.
So now the trials which have been done in this COVID era, they are basically on dagarelix and on enzalutamide, and for lowering the testosterone. And what is your take on that? The trials, in the practice, all the guidelines are recommending agonists, but the trials are not done on agonist. You think that that is already proven because of the requirement and adhering to the government policy and guidelines that less visits should be there, and that we accept, and why the trials we are talking, we can understand about enzalutamide, because that trial which has been done, that is to avoid steroids. But why for androgen deprivation therapy we have done the trials only with the dagarelix?
So
Dr. Bharat Vaswani can answer.
Sir, if you ask me, sir, I don't have any specific reason to say why you should give a monthly when the safest option should be 3 and 6 monthly to avoid frequent coming to the hospital. What we know is in this dagarelix is probably slightly better in terms of the fastness in which it reduces the testosterone level to the castrate level. Probably I feel that could be the reason that, and one more theory that has been postulated is androgens stimulate the production of TMRS22 gene, which is responsible for adhesion of COVID virus to respiratory epithelium. So earlier your androgens are down, the better or safer are the patient. That is something, that is a very big study that has come in the Lancet. So ADT is a better thing in terms of maybe reducing the morbidity and mortality in COVID times for SARS virus. And what, according to me, the faster drug to act in this time could be a dagarelix. So probably they might have tried, but they might have avoided that they have to come, the patient has to come every monthly. That is what I can understand from the trial.
Their trials, because that they wanted to avoid the testosterone or the fluctuations in the testosterone. But in the long run, we all agree that goserelin, Joladex, or other class agents, LHRH, are more useful, and enzalutamide is more useful, and abiraterone is more useful compared to enzalutamide, this abiraterone. So the patient asked that hormone therapy is going on. Will this continue? It will be normal or change. We have already discussed that antagonist can be changed to agonist, and sometimes we are giving docetaxel, but we can change to anti-androgens, and like we are changing to single agent therapies also, like earlier pembrolizumab and plus axitinib was given for RCC. We are giving now axitinib alone in this COVID times. The PSA screening or imaging is to be done 3 monthly, or it is to be changed. Dr. Janak is there? Or yes, Dr. Suman, you can answer that how you monitor it.
Yeah, we are doing PSA before each hormonal injection. If the patient is receiving 6 monthly injection, we are doing PSA 6 monthly in this time. And if they are receiving 3 monthly injection, we are doing PSA 3 monthly.
So basically,
but otherwise we do PSA 3 monthly.
Okay, so for doing PSA, patient need not to come to the hospital,
That is what.
and that monitoring will continue. And palliative terminal care issues are there because we are finding many patients who are otherwise known asymptomatic, and they are found to be positive, and therefore we have taken this palliative care, terminal care issues are very important now. And death is also important, because if the death is in the hospitals, we are not giving the body without COVID testing for obvious reasons. So general principles for prostate cancer early detection during COVID is avoid routine patient screening, defer further testing, and in rare conditions go for if the diagnosis of lethal prostate cancer is there, then we go for biopsy. Otherwise, biopsy is also deferred, and if you compare, imaging is also deferred. But if you compare biopsy with the imaging, the biopsy imaging is better, and biopsy, if we are going, then complications, that is because of infection, infectious complications, they are more going to be there. And if you think that it is the slow growing tumor and we can wait, the biopsy can also be deferred for 3 months or till 6 months, 3 to 6 months. And management about the radiation therapy, already it has been told, and across all prostate cancer stages, telemedicine consultations are important. But telemedicine, as Dr. Janak Desai also mentioned, telemedicine is not possible unless you see the patient once, and it is allowed as per law for next 6 months. So 1 to 6 months consultations can be there, and treatment can be delayed, and if the it is low volume disease or intermediate risk, low or intermediate risk. In unfavorable intermediate risk, high risk, clinical node positive, recurrence post surgery, or oligometastatic and low volume M1 disease, they can receive new adjuvant hormone therapy for 4 to 6 months before starting the radiotherapy. And also ultra hypofractionation already has been told, and salvage is preferred to adjuvant radiation. We were just listening to Dr. Saini that salvage compared to salvage, adjuvant is important, but here in COVID times the salvage is preferred. And also medical management can be the remote visits, the telemedicine we have already discussed. And what is to be avoided is prophylactic whole pelvic radiation therapy. Patients with very low or favorable intermediate risk should not undergo further staging, active surveillance, or confirmatory testing, monitoring, and treatment until safe. And for patients with non-metastatic disease, avoid inflicting androgen if the doubling time is more than 9 months, but this is doubtful. Here we were discussing that if you are able to lower the testosterone, it is good for the patient in COVID era. Once ADT is initiated or intermittent ADT is started, consider remote telehealth visits and also defer patients with asymptomatic, afavorable, high risk and very high risk, defer further staging and radical treatment until deemed safe, and neoadjuvant ADT should be considered. Individuals who have received definitive treatment for their cancer with either radiation or surgery would defer initial post-treatment monitoring, PSA-based testing for some time until they deemed safe in this pandemic era. And data from Johns Hopkins suggests delaying surgical treatment for upward for biopsy diagnosis will not negatively impact their outcomes. So we shorten or reduce the consultations, that they can be prolonged. For symptomatic patient, conservative measures should be implemented, and we should give the hypofractionation of radiotherapy. Encourage and educate the patients to have the adequate supply of oral cancer medication and supportive cancer medication on hand, so that they don't have to visit hospitals or medical stores, and because they are aged patients, and defer repeat imaging over time if PSA is declining, and also patient receiving chronic steroids and their caregivers, that if they become sick, they may need stress dose steroids. Communication with the patient and the primary care provider is very important, because they are old age patients, and many NGOs and many resident welfare associations are active in this area, and that help can be taken from that. So with this, I invite if there are more comments by the panelists on this issue. Finally, Dr. Bharat Baswani is there, Dr. Suman is there, and I'm seeing Dr. Janak has just left. Yes, Dr. Bharat and Dr. Suman.
Sir, whatever said, everything. Suppose in any circumstances we need to give chemo, that is in castrate-resistant prostate cancer with a rapidly increasing disease, we need to give liberally growth factor. That is something. So the most important thing is we need to avoid it. So use of colony stimulating factor should be more liberal here, not judicial. You don't have to wait for neutropenia. And now one more thing that has come up is, normally we give growth factor 24 hours after chemo. But some data, they suggest that on the same day you can give it off and can send the patient at home. Second different thing what we have started doing is, we have sent, if any checkup to be done, we are sending the sister to the home only. So we have arranged that home care system nowadays from our hospital. So whenever we require any blood checkup, we are sending the sister there, they are collecting and then sending. We have a telemedicine for laboratory things. So these two things added on we are doing, sir. Now.
I'm seeing Dr. Anish Srivastav also. Dr. Anish?
Hello.
You have some comments on this?
Yeah. I thought, Doctor, is Dr. Gagan Saini around, or one of the medical we can also answer my
Bharat Vaswani.
I'm a medicine, yes.
Okay, Bharat. So this is regarding that debate, or not the debate, the talk taken by Gagan regarding the localized cancer prostate, T3, N0, and adjuvant versus early salvage. So I have just two queries. I heard the entire thing that Dr. Huku also very nicely summarized. Now there are situations when the overall profile is mixed kind, like the Gleason may be low and the PSA may be high. So what is the role, and it is only the T3, N0. So what is the role of post-operative PSA? Should it be less than 0.5 or 0.2? If you say between 0.2 and 0.5, I will straight away go for adjuvant therapy. Then what are the your comments, and in such a situation whether we can still go for early salvage? the role of post-operative PSA, immediate post-operative PSA, cut-off kind of thing.
Dr. Suman?
Yeah, it's a usually we follow 0.2.
Okay.
So yeah.
So actually, Dr. Seni has mentioned that if it is 0.1 also,
0.1.
or the
0.1.
0.1 and consecutively increasing PSAs even below 0.3 PSA, even below 0.1. Now they are considering early
Early relapse. Yeah.
That is when you are waiting. I think when you go for early. I was talking about adjuvant. Should we straight away give them adjuvant because
that
there
is
is
histological
you guys
features and other features. We can give adjuvant also. But PSA, if 3 consecutive, you are saying that comes in early salvage therapy. But now we are discussing in COVID era that this therapy, the early salvage therapy, maybe for 3 to 6 months, we are not considering at this stage. And it can be the salvage radiotherapy also, because that you have to modify the radiotherapy doses also, and also timing also. And it is better that you give 3 to 6 months for the hormones before the radiotherapy is employed. So, Doctor, I think we have deliberated. We can keep on deliberating tomorrow also. And Dr. Arun Chawla is with us, who is co-chair with me in Indian School of Urology. That is the Urological Society of India. I think we have already overshoot, and I'll give this is our honor that he will be. He is from Manipal, and he is doing a lot of work. Tomorrow's program he has scheduled. In the morning, Dr. Anish is immediate past board of education, and we are very lucky till the end. All the stalwarts are with us, and I'll ask now Dr. Arun Chawla to give a vote of thanks for today and tell the program for tomorrow. And before that, Dr. Arun Chawla is doing on behalf of Indian School of Urology along with me. I'll give the mic to Dr. Umesh and Dr. Hemant Goel. Hemant has just appeared. He's sitting with Umesh. This is surprising. So yeah, so first Dr. Hemant, your comments on this discussion.
Yeah, so, sir, we were just sitting together. So, sir, excellent discussion. I think both day 1 and day 2 program were excellent, and we learned a lot from these 2 days. So, we are looking forward for day 3 of this program. I think Dr. Umesh can chip in.
Thank you, sir. Thank you, all the chairpersons and the galaxy of speakers. I really thank them for their time and their devotion for this conference to make a big success. And this is a holistic approach on the prostate cancer symposium. And I would like, we too have drafted this program under the guidance of Dr. Rajiv Sood sir. And I thank Dr. Sood sir for giving this privilege to organize this conference, a webinar, and we are looking forward for such a program in the near future. Over to you, sir, for the closing remarks, and it's a great opportunity for
I have already given the closing remarks. On behalf of Andrology India, Genitourinary Cancer Society of India, and also Urological Society of India, and also the so many people have now joined, individuals also. After thanking all of you, and with this great success of these 2 days master class, we have very important day tomorrow, and Dr. Chawla is with us, and he will be speaking on behalf of Urological Society and about tomorrow's program. Dr. Arun Chawla, over to you.
Thank you, Dr. Rajiv Sood. First of all, an excellent program. It was very well scripted by Professor Rajiv Sood and beautifully executed by his team members. all the presentations were very good, backed by recent literature evidence. And the added value was of selection of case discussion, the cases for the case discussion. The deliberations during the time of case discussions was very good. And the program value got enhanced, truly enhanced by the presence of the likes of Professor P. Venugopal, Dr. N.P. Gupta, Dr. Sudhir Rawal, Dr. Mahanti, Dr. Janak Desai, Dr. Anish Srivastava, the likes of Yuvraj, Janil, Anil Mandani, and many other stalwarts, not only from the field of uro-oncology, but as well as from radiation oncology and the medical oncology. It was very nice to hear the perspectives from the speakers from medical oncology and radiation oncology on different issues. So that was very interesting to listen to them. Overall, this 7.5 hours for on personal front was a revision of full carcinoma of the prostate along with the recent advances. I enjoyed this 2 days of session very much. Tomorrow also we have on the behalf of Indian School of Urology and Urology Society of India a similar program on the cancer prostate. This is divided into 3 sections. The first section is on the diagnosis on the biomarkers. Then we have the various imaging modalities as well as advancement which has taken place in the imaging. Then we have some diagnostic dilemma in the advanced prostatic cancer in its management or in its evaluation, and probably which will be followed by a nice case discussion. So overall, what you have 2 days of extensive deliberation of cancer prostate, you will have a capsule in three hours. Overall, excellent program. Congratulations to all the speakers for beautiful presentation, the chairpersons, the moderators, the panelists, and the discussants. Thank you to Dr. Rajiv Sood. Thank you very much.
This will be available, this program. The links will be sent, and anybody at leisure can listen to this. This is the complete program and very well executed by Dr. Hemant Goyal and Dr. Umesh Sharma. Both are the faculty at Ram Manohar Lohia Hospital. I'm on behalf of Urology Society of India also, Indian School of Urology, and Genitourinary Cancer Society of India. Along with that, RML Hospital also is thankful to all the participants, faculty, and good wishes from all the people. And the way this has been attended yesterday and today, the registrations are more than 500, and at any given time on Facebook and the proceedings, not less than 300 people were logged in. So this is a huge success, and we continue this success tomorrow also in the morning. Thank you very much. Thank you again, my team of Dr. Hemant, Dr. Umesh, Dr. Anurag, Dr. Sumit.
A lot of congratulations to Umesh and Hemant. Very good work done. Beautiful.
Very well done. Very
well done. Extraordinary work. Yes, sir.
Yes. I would also like to thank the Horizon Conference, Mr. Tarun and Ms. Pooja for logistic support.
That was the great support to tie all the people, and all the registered people also remind them to be with us during all these deliberations, and very extensive deliberations, and most of the time all the people were logged in. That is a great achievement. And thank you very much. Thank you.
Thank you, sir. Thank you. We close the meeting, sir. Sir, we close the meeting now?
Yeah.
Thank you, Dr. Anish.
Good night.
Goodbye.
Bye.
Dr. Rajiv, goodbye. Amesh, Rahul, goodbye. Goodbye, everybody. Yeah.
Goodbye.
Good night. Good night.
Right.
Hello.